All right, so we're talking about normal pregnancy again, chapter 65, normal pregnancy. So this is going to be the introduction about normal pregnancy. Let me zoom in. So, okay, I'll just back up. All right, normal pregnancy. Introduction. So, with normal pregnancy, during the woman's reproductive years, the female body is designed for conceiving and bearing children. The key concept to remember is pregnancy is a normal physiology or physiologic process. It's not a disease. Uh, in certain um, in certain cultures, they think it's a disease, but it's not. Defining pregnancy as a normal process. Gestation is the period of time that occurs from the moment a man's sperm fertilizes a woman's egg until the birth of the newborn. How I remember the word gestation, I said the sperm just stayed in the vagina, and now the woman is pregnant. You know, it just stayed in there and it fertilized the woman's egg, and now she had a baby, and it is what it is. So the sperm just stayed up in there until she had a baby. That what I'm saying, just stayed, because that helps me remember gestation. So, or if it's gestation, but I'm gonna pronounce it gestation. It is a period of time that occurs from the moment a man's sperm, so the man's sperm just stayed inside the vagina. It fertilized the woman's egg until the birth of the newborn. So the sperm just stayed in the vagina until it created a baby. Fertilization, that's going to occur about 2 weeks after a woman's last normal menstrual period. So remember that fertilization that takes place about 2 weeks after the last normal menstrual period. Based on the common use of the calendar year, hold on, I like to record myself so I can take a break. Well, I time myself. My bad. Okay, so hold on. 30, I'm gonna say about 30 minutes, and then I'm gonna take a break. So, based on the common use of the calendar year, pregnancy is divided into 3-month trimesters. The first trimester begins on the first day of the woman's last period and ends on the last day of week, which is the 13th week. So that's the first day in the 13th week. So the first day is within the first week, as we know. And then a second trimester includes week 14 through 27. So how I remember week 2, 14 through 27, I said 7 times 2 equals 14. 7 times 2 equals 14. I'm just remembering the 27 and the 14. And then the third trimester begins at 28 weeks and extends until the pregnancy is expected at the end of 40 weeks. During the 40 weeks of pregnancy, the woman may be referred to as a gravida. That is the Latin term for a pregnant woman. It is her first pregnancy. So let me highlight that. So gravida, however you want to pronounce it. It's a Latin term. During the 40 weeks of pregnancy, the woman may be referred to as a gravida, the Latin term for a pregnant woman. It is her first pregnancy. Well, if it is her first pregnancy, she's a primogravida. If she has had other births, she is multigravida. Let's say she had the baby. So that's going to be the word para. Para refers to the parting of the mother and the baby or the birth itself. And then the woman who is you know not an amateur to having these babies back to back, back to back, back to back, she is a grand multipara. So pregnancy is also called the antepartum period. You got the antepartum period. Therefore, hold on, y'all, let me turn this goddamn PlayStation off. Okay, so I think I stopped it right here. Okay, so pregnancy is called the antepartum period. That means you're pregnant, but it's during the pregnancy, and therefore prenatal care, that's care before the birth. may also be called antepartum care. So the period of pregnancy or the pregnancy itself is called antepartum period. And that care that the uh, pregnant lady receives while pregnant, or the mother to be, is the antepartum care. Now, good prenatal care is one of the most important factors in the health of the mother and the babies. Obstetrics is the branch of medicine for pregnancy and birth. What that's concerned with pregnancy and birth. Physician who practices this specialty is called an obstetrician. We know it as the OB. A registered nurse that's going to who specializes in the training and the management of the labor and birth is called a midwife or certified midwife. Nurse midwives are specialists who work with healthy women during their pregnancy, and the key word is healthy. They work with healthy women during their pregnancy. Now they can work with some women at high risk, but they have to refer them to a OB. They have to refer them to a OB. That's for high risk pregnancy. So they're really not going to be, you know, by themselves as far as taking care of or helping a woman or a mother to be with serious health risks. So review this chart, know this chart. G is for gravida. And this is, and basically these are the abbreviation and terminology used in obstetrics, if I'm saying it right, obstetrics. I just say OB hell. G is for gravida or gravida, the number of pregnancies, regardless of the outcome. So it's regardless if the baby made it or not, regardless if you had an abortion or not. This is the number of pregnancies, regardless of the outcome. Parity, P is for parity. Parity is the number of deliveries. Parity, the number of deliveries. Parity, the number of deliveries. Parity, the number of deliveries. P, parity, the number of deliveries. T is for term. T is for term. T is for term. T is for term. Term is a pregnancy greater than 37 weeks of less than 42 weeks of greater than 2,500 grams. T is for term, and that is the pregnancy greater than 37 weeks or less than 42 weeks or greater than 2,500 grams. Okay. um GT Pal, GS, you see GT Pal. GT Pal, G stand for gestation, T stand for term pregnancy, P stand for preterm pregnancy. That P stand for preterm pregnancy in GT Pal. The A stand for abortion and the L stand for live birth. The L in GT Pal stands for live birth. Now when we go to TPAL, 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 T stands for term birth. That's 37-week gestation. The P does not stand for premature pregnancy. The P stands for premature birth. Premature birth. And the A stands for abortion, and the L stands for living children. Do not get living children mixed up in TPAL with live births in GTPAL. Okay. Gestation, also known as gestational age or the number of weeks from a woman's last menstrual cycle the current date, normal pregnancy, well, normal range is 38 to 42 weeks. Then you got live births. With live births, and so with so I think I said what gestation was, and so next with the live births, just remember that live births go with GT Pal, GT Pal. Living children go with TPAL. Living children go with TPAL. So with the live births, you got the total number of children who survived birth but may have died later on. They died any other time, any time later, often confused with the reference of living children. And then living children, this is the number of children that are living as of today and do not include births who died previously and can be confused with reference to live births. Preterm is a pregnancy of about 20 to 37 weeks or more than 2,500, but it's less than 2,500 grams. So it's more than 500 grams or less than 2,500 grams. Post term is the infant. The baby is here, right? So, well, the baby hasn't made it yet. It's greater than 42 weeks of gestational age. So, the infant inside of the stomach is greater than 42 weeks. So you went past your term, which is normally 40 weeks. So you done went past the 40 weeks. And then abortion, it can be spontaneous or therapeutic. That's a delivery of an infant by spontaneous or therapeutic mean. Perioperium, it's a time period between birth and 42 days after delivery, if I'm saying that right. Puerperium is the time period between birth and 42 days after delivery. Trimester, we already went over trimesters, but it's different on this chart actually. The book said the first day to the 13th week. Uh, and this is saying the 12th week. And then the second, the book says the second trimester was the 14th week to the 27th week. Remember when I said 7 times 2 equals 14 in the second trimester, but it says 13 to 28 weeks. And then the third trimester right here, it says 29 weeks, and the other one says 28 weeks to delivery, or to four, it really says 40 weeks. So applying the expanded classification to describe, so we're going to it's going to be something up in here. So when we're applying the expanded classification, y'all know, like when we did expanded, I think that was like PIMAS or whatever, PIMDAS, whatever in math, how you parentheses and uh, parentheses, and hell, I forgot what the E and all that shit stand for. PIMDAS, I think that's what it was. Parentheses, and the E stands for, I forgot. And then the M is multiplication, the V and D is um, dividing and shit like that. So we're trying to put this in expanded form. We're going to try to put some of this stuff in expanded form. This is the expanded form. So if that woman who is not now pregnant but has 4 pregnancies, she had, okay, so that's G4. She's been pregnant 4 times. That's Gravita 4. She had 2 births, 2 babies born at term. I mean, 2 babies born at term. That's where that come from. These are the 2 babies born at term. And then she had a one preterm baby. That's the one preterm baby. And she had 1 miscarriage. That's the 1 miscarriage. That was due to a spontaneous abortion. And you were right. G4, P2, 1 preterm, 1 miscarriage. That means she has a total of 3 kids, 3 living children. So I'm going to try to break that up down here so we can remember that. The Vita with a G equals 4, which is pregnant 4 times. The P, and y'all gonna have to write this down because I didn't include this in the stuff. P equals 2. That means she has, which means 2 babies born at term. The 1 equals 1 term, 1 preterm. So it was anywhere from between 20 and 37 weeks. And then the other one is 1 miscarriage. Uh-uh. Due to that spontaneous abortion. I mean, it wasn't an elective abortion. And then you would write, and that 3 equals 3 living children. So that's a total of 3 living children. Okay, so moving on, let's talk about the preconceptional care. Preconception, so that want to make sure G4, P2, 1, 1, and 3. Preconceptional care. Preconceptional care. This is the care of the woman before she is pregnant. It is an important healthcare priority. The goal of preconceptional care is to have the best possible pregnancy outcome for every mother and baby. It is important to perform preconceptional care because the earliest weeks of the pregnancy are the most critical in the human um, development. Okay, so preconceptional care of the woman before she is pregnant. This is before she is pregnant. All right. So, 7 areas that need to be addressed in preconceptional care. These are the 7 areas that need to be addressed. I'm going to highlight that whole thing because I think it's important to know. Because I saw some questions like this on when I went to go, I think, answer in the back of the book. So, 400 milligrams of folic acid a day because they help with the development of the baby brain. So, eating a healthy diet, including 400 milligrams of folic acid a day, stopping harmful or addictive behaviors. So, you need to stop all that smoking and popping beans and tooting powder and drinking alcohol and just using all them fucked up ass drugs, stopping use of prescription drugs that are known to be harmful to a developing infant. So obtaining prescription for alternate drugs that are safer for use during pregnancy. You want to make sure that that diabetic woman she changed the insulin instead of taking an oral diabetic agent and making sure her blood sugar is under excellent control. Referring a couple at risk of having a baby with a genetic defect for genetic testing and counseling before the pregnancy, testing the mother to be for any type of infectious diseases, and either providing immunization, rubella vaccine, or treating infections that are found, including HIV or other or STDs. Now, that this is all before she get pregnant, so she can get the rubella vaccine before she get pregnant. Once she get pregnant, she cannot get that rubella vaccine because it contains live something, live cultures, live bacteria, or something is live. So she cannot get that because it can harm the baby. But she can get it in preconceptional care. Reducing psychosocial risk factors, for example, helping a woman who is being battered to find services and helping or linking women with community resources. So, pregnancy precautions. This is the following is summary of essential precautions to discuss with each woman who is pregnant or who may become pregnant. Do not take any medications or drugs unless it was prescribed by a practitioner who knows that the client is trying to conceive or is already pregnant. You want to avoid x-rays whenever possible. If it's an emergency, yeah, you can do the x-ray. But if it's not an emergency and it's an elective x-ray, do that shit after the baby is delivered. You want to avoid substance it's like caffeine intake. Well, you want to limit your caffeine intake. Not saying you can't have your cokes, not saying you can't have your coffee and shit like that, but kind of limit those things. Avoiding tobacco, not no kind of limit those things. Avoiding tobacco, no nicotine when you're pregnant. Or if your baby daddy smoked them Benson and Hedges or Cools or whatever the fuck he smoked, tell him to back the fuck up out the room, go outside and smoke this cigarette. Don't smoke that cigarette around you. And you want to abstain from alcohol and powder and shit. That's recreational drugs. Avoid or limit exposure to known environmental toxins. So if you're working around a lot of chemicals and shit like that, stay the fuck away from it. You want to avoid exposure to infections, including rubella, because you can't fucking get a rubella vaccination while pregnant. So try to avoid that shit. Try to avoid getting the flu. Try to avoid being in areas that you know a motherfucker got tuberculosis and stop all that fucking around so you won't have no STDs. And if your baby daddy is known to fuck around, leave that nigga while you're pregnant. Okay, so also you want to avoid hypothermia producing situations such as hot tub. Get your ass in the hot tub if you want to, and the baby gonna come out like a goddamn mukbang, motherfucking shrimp crab boil. So do not get in the fucking hot tub because you're gonna fuck around and have an unseasoned ass baby. Also, you want to make sure that you have excessive, well, don't fucking do excessive exercise and no prolonged sitting in hot water. I already told you you're gonna fuck around and you're gonna have an unseasoned ass baby. Okay, so don't fucking do it. There are two types of preconceptional visits. You have visits by a woman or a couple planning a pregnancy. a woman who is not obtaining, well, not planning to become pregnant soon, but who may become pregnant. Those are the two visits for a preconceptional visit. It's going to be a woman or a couple who's planning to get pregnant, and then a woman who fuck around. She don't want no baby, but she might fuck around and get pregnant because her nigga can't stop skating in or his fucking pull out game is weak as fuck. So those are going to be the two type of visits. Stages of human development. Stages of human development. So conception and sex determination. Human life begins with the union of two cells. That's the ovum and the sperm, right? So just, all we need to know about this is this. Okay, so this union is known as fertilization or conception. When there's a union of two cells, that's the sperm and that's the ovum, basically the egg, right? So that's fertilization or conception when that sperm meets the ovum, and it usually occurs when the ovum is in the third outer layer. Want to know when it occurs? It occurs in the third outer layer. I'm sorry, third in the outer third of the fallopian tube. When the ovum is in the outer third of the fallopian tube, which is the ivy duct. At the time of conception, the sperm determines the sex. It is not us, ladies. It's not our egg. It's not our ovum. It's the sperm that determines the sex. The woman, the ovum, it only has an X chromosome. The ovum only carries the X chromosome, but the male chromosome is going to carry either the X or the Y, the X or the Y. So, um, okay, so boom, the sperm goes and it meets the ovum. That sperm is either going to be an X or that sperm is going to be a Y. The ovum is already an X. The ovum is this is the ovum. This first X, that's the ovum. But this is the sperm, that Y or that Y. That's the sperm. That Y indicates that this is a boy. And the X down here, the XX indicates that this is a girl. Okay. So this is just talking about the path to sperm and the frequent site of implantation and all that shit that goes on. Like I told you, the frequent site of implantation, um, or this union known as fertilization or conception usually occurs when the ovum is in the outer third of the fallopian tube oviduct. Also, okay, so the period of zygote and implantation, you got the period of zygote and implantation. The fertilized ovum or zygote is the beginning of the potential individual human development. During this time, the zygote divides rapidly until it forms a ball of about 16 identical cells, which is called the morula. At this stage, the first difference amongst the first differences among cells develop. Just before the morula reaches the uterus, the cells begin to form layers. First one, then the two layers around a was two layers surround a fluid filled space called the blastocyst. And then after that, another group of cells form that will become the embryo. And then as the blastocyst enters the uterus, the outer cell layer secretes an enzyme that permits it to burrow, meaning it's going to be implanted into the endometrium, or as it is known as during pregnancy, the pseudoa. And I probably fucked that word, decidoa. I'm not for sure how you pronounce that. So blastocyst, it's going to take about 7 to 8 days after fertilization. That's what it looks like. That's the human starting to get ready and develop before it turns into an organism. Well, the human is an organism. We are organisms. So this is what it looks like. You see the blastocyst is going to be right here, and then it goes down, and then it implants itself. That's the blastocyst, um, partially implanted blastocyst after 5 days. That's what it looks like, and that's the uterine endometrium, and that's when it starts to develop. So this is early human development and implantation. That's what this is all about. So if you want to look in your book at it, go and look in your book at it. Okay, so period of embryo. When it is fully implanted, the developing organism is called an embryo. When it is fully implanted, the developing organism is called an embryo. The outermost cell layer that surrounds the embryo and fluid cavity is called the chorion. I think that's how you pronounce that, the chorion. The outermost cell layer that surrounds the embryo and fluid cavity is called the chorion. And some of these outer cells send out projections like the chorionic villi, which are the roots, through which the developing embryo receives its oxygen and nourishment from the mother. Critical period of development. During the period of the embryo, which lasts until the 8 week after conception, the embryo is in what is known as the critical period, what the critical phase of human development. During these weeks, all organs and structures of the humans are formed and are most susceptible to damage. Key concept to remember is the first 8 weeks of pregnancy are critical or the critical period of the human development. During this time, all major systems of the embryo develop. In those first 8 weeks, all major systems of the embryo develops. The embryo and to a lesser degree, the fetus is vulnerable to a number of potentially harmful influences that could result in congenital defects. Gene determination or gene determines the basic embryonic structure. Therefore, a defective gene may be responsible for certain congenital defects. So that's going to be due to the gene. And then, or it can be just simply environmental factors, such as tobacco or alcohol use can cause congenital anomalies, such as we know as birth defects, like with alcohol, there's fetal alcohol poisoning, and you can tell by just looking at that child, you know, about the fetal alcohol syndrome. So this is the critical phase of human development. This is telling you what is going on in those weeks leading up to having the baby. Give me a second. I don't know. We might need to know this shit. Then again, I don't know. I really don't fucking know. So I'm going to read over it. I'm not going to really just beat myself up behind this shit, but I'm going to read over it. Give me a second. Okay, so we got the in the 4 weeks for the critical phase. Basically, this is just the normal fetal growth. So in the 4 weeks, you're gonna have the throwoblast embedded in the Sidua Sharonic villi forms foundation, and those are the roots. Those are the roots where the oxygen and the nutrients come from. In the first 4 weeks are going to be formed. The foundation for nervous system, like the GI system, the skin, bones, and lungs are formed. The buds of the arm and legs begin to form. The rudiments of eyes, ears, and nose appear in the first 4 weeks. And then in 8 weeks, the embryo is markedly bent. See how it's bent? The head is proportionally larger, well, disproportionately large. So that's a big ass head owing to the brain development. Sex differentiation begins. So, it's starting to figure out, if this is a boy or a girl in the 8 weeks, but we wouldn't quite know just yet. Center of bones begin to ossify. That means the bones begin to harden, to ossify, and the heart pulsates. It's starting to get a little beat to it. And then that was in the the 4th week and the 8th week. If I were you guys, if you want to remember this shit, I will put it on the index card. 12 weeks, 12 weeks, normal fetal growth. So we got the fingers and toes are distinct. Placenta is complete. The fetal circulation is complete. The organ systems are complete. Everything is complete in the first 12 weeks. The organ systems are complete. Fetal circulation is complete. The placenta is complete. The fingers and toes are complete. In the 16 weeks, you got the sexes differentiated. So we know whether or not this is a boy or a girl. In the 16 weeks, rudimentary kidney secretes urine. The heartbeat is present. The nasal septum and palate is closed. If it's not closed, that's how a lot of kids get that cleft palate. So in the 16 weeks, all of that needs to be done. So we can figure out if this is a boy or girl in 16 weeks. That's 14. What's 16 weeks? That's um that's 4 months pregnant. You can that this is going to be a boy or a girl. Rudimentary kidneys secrete urine. Heartbeat is present. Nasal septum and palate is closed. In the 20 weeks, you got a furry ass, hairy ass baby. That's what Lanugo stand for. It covers the entire body. My baby came out looking like a little pit bull puppy because he was born early. So Lanugo. hairy ass baby. You got the fetal movements are felt by the mother in 20 weeks. The heart sounds are perceptible by auscultation. I mean, you can hear the heart sounds by auscultation in the 20 weeks. And then the 24 weeks, the skin appears wrinkled. So in 24 weeks, you got this wrinkled ass baby. The vernix caseosa appears. Um, that is, let me see what that is again. That is hold on, because I don't like reading shit and I don't know what it is. Yeah. Vernix, CAS, caseosa. That is white creamy. Okay, yeah. That's that white creamy naturally occurring biofilm covering the baby. So you know when that baby born, they got the little white shit all on them. That's what that is. The vernix caseosa appears. The eyebrows and fingernails develop. The eyebrows and fingernails develop in the 24 weeks. And then moving on to the 28 weeks. Red ass baby. The baby is red in 28 weeks. Skin is red. The pupillary membrane this disappears from the eyes. That's basically that little thin layer of skin over the eyes. Like if you ever cook some ribs and on the back of the rib, you're supposed to pull the damn membrane off so you know you don't eat that, and so the ribs won't be so tough. So that's basically what a membrane is. So the pupillary membrane disappears from the eyes. The fetus has an excellent chance of survival in 28 weeks. The eyes open and close in 28 weeks. Now, moving on to the 32 weeks, the fetus is viable. Fetus is viable, meaning it has a high chance of surviving, just like we just said, excellent chance of survival. So this baby can survive at 32 weeks. It's pretty much complete. Eyelids are open, fingerprints are set, vigorous fetal movements occurs. That means that baby won't sit his ass down in 32 weeks. That's what vigorous means. And then the 36 weeks, the face and body has a loose wrinkle. So, you know, in 24 weeks, that baby was wrinkled as fuck. But in 36 weeks, that baby is, you know, skin started to get loose because subcutaneous fat deposits. The baby start to fatten out. That's why it's less wrinkle. When I had my baby, because he was 2.2 pounds, he was a wrinkle ass, hairy ass baby. He came at 27 weeks. At 37 weeks, guess what? The little go disappeared. See, my baby had told you he looked like a pit bull puppy because he was at 27 weeks, so he was furrier than the motherfucker. So Lanigo disappears, and also amniotic fluid starts to decrease. So that's when that baby starts to drink that 400 milliliters of amniotic fluid daily. Um, but we'll get to that about the amniotic fluid. And then in 40 weeks, you got that smooth ass baby. You got a smooth ass baby ready to come out. The eyes are uniformly flat color, and bones of the skull are ossified and nearly together as sutures. That means the bones are hard. They're pretty much hard, except, you know, we know this isn't all the way hard. And then the baby bones are still kind of brittle, but they're pretty much hard, ossified. You know, they're not as brittle. Now let's talk about the period of the fetus. The period of the fetus lasts from the beginning of the ninth week. We already talked about the period of the embryo. This is the period of the fetus. So this lasts from the beginning of the ninth week after fertilization through birth, which is usually at about the end of the 40th week of pregnancy, which is usually at about the end of the 40th week of pregnancy. This is a period of increasing growth, differentiation, and functional development of the tissues that appeared during the embryonic period. At about 20 weeks of gestation, the fetus becomes viable. That means having some chance of life outside of the uterus. Growth, growth and development before and after birth follows the cephalocadal, that's the head to toe principle. So the growth and development before and after birth is going to follow the cephalocadal, that's the head to toe principle. So growth and development starts at the head and it works its way down to the toe. Okay, the head to toe principle. I'm gonna highlight all that. So a newborn weighing less than 2.2 pounds is considered immature. That's an immature baby. Not saying necessarily it's premature because if it's born full term and it's 2.2 pounds, that's still going to be an immature baby. Not saying that it will happen, not saying that it can happen. It may be rare. A newborn weighing 10 pounds, that's 4,540 grams, are often difficult to deliver. However, the smaller the child is at birth, the less likely his or her chances are for survival. So if you got that fat ass baby coming out, that baby is difficult to deliver. But if you got a thin ass baby, a smaller chance, smaller the child is at birth, the less likely the chances are for survival. But my baby survived, thank God. So placenta and umbilical cord. The fetus, chorionic villi, eventually meets with an area of the uterine tissue to form the placenta, which is an organ with a rich blood supply. That I would know all of this. What the placenta does is it supplies the developing organism with food and oxygen. It carries waste away from where it carries waste away for excretion by the mother. It slows the maternal immune response so that the mother's body does not reject the fetal tissue, and it produces hormones that help maintain the pregnancy. That's what the placenta does. Once again, the placenta it supplies the developing organism, which is the baby, with food and oxygen. It carries waste away for excretion by the mother. It slows the maternal immune response so that the mother's body does not reject the fetal tissue. And it produces hormones that help maintain the pregnancy. That is the job of the placenta, which is an organ with a rich blood supply. So, using its chorionic villi, remember these are the roots. Within the placenta, the fetus secures its oxygen and food directly from the mother's blood instead of using its own lungs and digestive system. So the baby isn't using its lungs yet. The baby isn't using its digestive system yet. It's using those chorionic villi, which are the roots, roots, the roots within the placenta for to get the oxygen and the food from the mother's blood, directly from the mother's blood. The absorption of nutrients, excretion of waste, and exchange of gases occurs across the walls of the placental villi and the fetal blood vessels they contain. The absorption of nutrients, excretion of wastes, and exchanges of the gases occur across the walls of the placenta villi and the fetal blood vessels they contain. The fetal and the maternal blood are separate. Fetal and maternal blood are separate. Okay. By term, the placenta is approximately 15 to 20 centimeters in diameter. That's 2 to 3 centimeters thick and weighing between 5 to 600 grams. That's the placenta. The weight of the placenta is about one sixth the weight of the infant if both are healthy. So a healthy placenta is going to be about 5 to 600 grams. And the umbilical cord consists of two arteries. I think we need to know this. The umbilical cords have two arteries and one veins. It consists of two arteries and one vein that's twisted around each other. The umbilical cord is approximately 20 inches long. It's 20 inches long. A soft jelly-like substance called the Wharton jelly protects the cord, which enters the fetus body approximately in the middle of the abdomen at the umbilicus or the navel. Once again, a soft jelly-like substance called the Wharton jelly protects the cord, which enters the fetus body approximately in the middle of the abdomen at the umbilicus or navel. So this is a picture of the umbilical cord. You got the umbilical arteries and you got the umbilical vein. And see how the arteries wrap around the vein? The vein carries the oxygenated blood. The umbilical vein is going to carry the oxygenated blood, while the umbilical arteries, it carries deoxygenated blood. I mean, it just rarely doesn't have any type of oxygenated blood in the artery. So that's what we need to know about that. I wouldn't too much worry about this, but this is what the chorionic villi look like. These are the roots, and those are capillaries, villi capillaries, shit like that. Okay, so let's talk about the fetal blood circulation. With the fetal blood circulation, it differs from the newborn and adult circulation. The woman's blood supplies food to and carries wastes away from the fetus. Woman's blood supplies food to and carries wastes away from the fetus. The uterus expels the placenta, which is called the afterbirth, following the newborn's delivery. While the fetus is in the utero, the placenta returns deoxygenated blood, low in the oxygen, low in oxygen blood from the fetus to the mother through the two umbilical arteries. And in the veins, that's oxygenated blood, like I just told you. That's oxygenated blood. So the placenta returns that's oxygen rich blood to the fetus through a single vessel, which is the umbilical vein. Some oxygenated blood from the umbilical vein passes through the fetus liver, but most of it enters the fetus inferior vena cava through the ductus venosus. This short duct is found only in the fetus and atrophies after birth. That means it withers away. It just shrivels up after birth. From the inferior vena cava, the blood flows into the fetus right atrium. Because the fetal lungs are not functioning yet, or not yet functioning, most of the blood is shunted to the heart's left atrium. This shunt occurs through another fetal structure, the foramen ovale, which is an opening between the right and left atrium. The structure permits most of the blood to bypass the right ventricle. A small amount of blood passes from the right atrium to the right ventricle and makes its way into the pulmonary artery. This blood is then shunted through the ductus arteriosus, which is a connection between the pulmonary artery and the aorta that allows shunting of blood around the fetal lungs. Normally, with the newborn's first few respiration, the lungs expands as soon as the pressure within the chest alters. The foramen ovale closes and the ductus arteriosus and ductus venous shrivels and become fibrous ligament. Now, I said all of that, um, and I didn't highlight anything because these two are going to be the most important. So the foramen ovale closes and the ductus arteriosus and ductus venous shrivels and becomes fibrous ligaments. That's after the baby takes his first few respiration. And congenital heart defects in a child occur when these events do not take place after birth. So if none of that shit happens after that baby is born, that's going to be a congenital heart defect. A congenital heart defect in a child occurs when these events do not take place after birth. NCLEX alert to remember is transference from fetal circulation to adult type circulation is a common cause of post birth problems. So this is everything that's going on with the umbilical cords, ductus venous, the foramen, ductus arteriosus. That's what all it is. So with the membrane and amniotic fluid, let's talk about that real quick. So with the membrane and amniotic fluid. So as the embryo grows, most areas of the villi atrophy, that means it withers away, leaving only a disc of villi that develops into the placenta. The rest, the rest of the chorion becomes a smaller outer membrane for the embryo. Inside it, other cells eventually form a fluid-filled sac, which is known as the amnion, in which the fetus floats. That is how the fetus floats. So that's basically the amnion fluid. The amnion is the inner layer surrounding the fetus. These two membranes form a tough protective bubble for the developing embryo and fetus, protecting it from organisms that might infect the mother's cervix. In addition, the membranes are important to hormone production and also play a role in the onset of labor. The amniotic fluid keeps kept inside the amnion performs the following function. The amniotic fluid, it cushions the fetus against injury. It regulates temperature. It allows the fetus to move freely inside it, which allows normal musculoskeletal development of the fetus. In late pregnancy, the amniotic fluid is made up primarily of fetal urine and fetal lungs. In the late pregnancy, you got the amniotic fluid. It's going to be made up of the fetal urine and the fetal lung fluid. Near term, the fetus swallows almost 400 milliliters of amniotic fluid each day and then excretes it into urine. Therefore, a defect in either the ability of the fetus to swallow or in its kidney function can dramatically change the quantity of the amniotic fluid. So, know what can dramatically change the quantity of the amniotic fluid. It's going to be the swallowing of the baby or the kidney function. So, the quantity of amniotic fluid increases about 1,000 milliliters, 37 weeks of gestation. Once again, the quantity of amniotic fluid increases to about 1,000 milliliters by 37 weeks of gestation, decreases slowly until 40 weeks, and then decreases much more quickly if the baby is not born by the end of the 40th week. I will highlight that. The quantity of amniotic fluid increases to about 1,000 milliliters by 37 weeks of gestation. Now, because of this predictable pattern in the quantity of fluid, one measurement of post-term fetal well-being is the volume of amniotic fluid. This is important to know. Because of predictable pattern in the quantity of fluid, one measurement of post-term fetal well-being is the volume of the amniotic fluid. So that's the post-term fetal well-being is is the volume of the amniotic fluid. It's just pretty much a predictable pattern in the quantity of fluid. So, changes in a woman's body during pregnancy. So, many of the changes in a woman's body during pregnancy can be externally. It also can be seen internally as well. Some of these changes are caused by the growing size of the fetus, but even more changes result from the unique hormonal environment caused by pregnancy. So the changes of the woman's body is due to the growing fetus and also due to hormones. Now let's talk about the signs of pregnancy. You got the presumptive, probable, and positive signs. Presumptive, this is something, this is more objective. This is due to a woman, this is a possible sign, but it appears in the first trimester and often only noted subjectively by the mother. So we can't see this. Well, we may see her, vomit and, stuff like that. And we may see breasts get a little bit bigger, or we can't see if the breasts are tender or anything like that. But we can't just go off of that saying that of course she's pregnant. So presumptive, this is first trimester and it is subjective. Probable, and then you need to know all of these for presumptive. And then probable is likely signs. It appear in first and early second trimester, seen through objective criteria, but can also be indicators of other conditions like hydatidiform mole. So they're probable. We can look at it and we can say, yeah, you might be pregnant, objectively and subjectively, but we cannot just say that you're pregnant. We can't say that it's positive until we have proof that exists that are developing fetuses in a trimester, in any trimester, and that's going to be due to an ultrasound. When you have an ultrasound, that baby is for sure, you are pregnant. Positive means that proof exists. So you got presumptive, which is subjective, probable. It can be seen as objective criteria, but that doesn't necessarily mean that that it's pregnancy. We can't just say, okay, you're pregnant, alpha probable. But we can definitely say you're pregnant because we saw the baby with the ultrasound for the positive. That means proof exists because we did an ultrasound. And presumptive and probable signs are primarily caused by hormonal changes that occur during pregnancy, primarily caused by hormonal changes that occur during pregnancy. That is how presumptive and probable signs come about. And most presumptive signs appear early and are subjective. And that is, they may be only noted by the woman. However, these symptoms could indicate a condition other than pregnancy. Probable signs also appear early in pregnancy, but they are more objective. Often, both healthcare personnel and the client herself can observe probable signs. And only the positive signs of pregnancy will provide proofs that there is a fetus, a developing fetus. I just said all of that shit over again. So key concept: pregnancy is not confirmed until the existence of a fetus can be proved, and that is with the positive sign. Now let's talk about presumptive signs of pregnancy. And now this is presumptive. So there's amenorrhea, nausea, frequent urination, fatigue, quickening, breast changes, and pigment changes. This is objective. All of this is objective, and it doesn't necessarily mean that a woman is pregnant. So I would know these. If it's a select all that apply, we know what amenorrhea is. We know what nausea is. We know what frequent urination is. We know what fatigue is. We know what quickening is. We know what breast changes is, and we know what pigment changes are. So, but let's go over it. Amenorrhea. She's not having a period. That's the first indication that she's pregnant, right? So, a missed menstrual period, however, does not always signify conception. Pregnancy is dated the first day of the woman's last normal menstrual period. That's when you say she's pregnant. After the first day of the last normal menstrual period, to be considered normal, um, she for the period to be considered normal, the period should have come on time, last as long as it usually does, and have been the normal flow of period. If any of these three items are not true, then the client needs to recall the first day of her previous menstrual period. Have her to do that. Nausea that can begin in the first, like after the first missed period or the first missed menstrual period, and usually disappears after the third pregnancy. If the condition lasts beyond the fourth month, results in a loss of 8 pounds, well, weight loss of 8 pounds or more, or affects the woman's general health, it is considered a complication of pregnancy. We know that as hyperemesis gravidarum. So know what that is, know what that is, and know what it does if nausea lasts longer than 4 months. And then frequent urination, that's due to the enlarging uterus pressing up against that urinary bladder. Late in pregnancy, the woman again feels the need to empty her bladder frequently. Once again, this is caused by pressure as the fetal head moves downward before birth. Fatigue, that's during the early months of pregnancy. The woman may feel drowsy and may tire easily. Um, that's during the early months of pregnancy. Quickening, the first fetal movements, that's what we know as quickening. The first fetal movements that the pregnant woman feels are called quickening. The woman usually experiences quickening is going to be between the 18 and 20 weeks of gestation, but it may come on a little bit earlier if this is, if she's been pregnant more than once. It may come on like a week or two earlier. Women describe quickening as a light fluttery. It's described as a light fluttery sensation. I know that's going to be on the test. This feeling of life is not considered a positive sign, though, of pregnancy because it cannot be confirmed. It cannot be confirmed objectively. We can't, like a doctor or a nurse, we can't say that, oh, yeah, she's pregnant because of fluttery. We can't feel that. We can't see that. You know what I'm saying? So by anyone other than the woman herself, that's who feels it. So it's a subjective. That's why it's in presumptive. Now the movement of gas within the colon can give you also that type of it can have that simulate this feeling. Breast changes, the earliest changes of breast, they are similar to a menstrual period. However, the sensation during pregnancy are more intense than premenstrual changes. So, sensation includes breast enlargement, heaviness, tingling, throbbing, or tenderness. As the pregnancy progresses, the areola, and the nipples enlarge and darken. So you got these big symbol looking ass nipples. By the 14th week, the woman's breasts begin to produce colostrum, which is a clear or slight milky fluid will be produced in very small amounts throughout the rest of the pregnancy and is greater in quantity during the first day or two after birth. That's when your titties start leaking, and after that, her true milk will come in. So know what that is. And then pigment changes. Pregnancy causes some skin changes. A suntan bronze masking may appear across the face of dark haired women. This is known as melasma, or you can call it cloasma uh, gravidarum, or the mask of pregnancy. This is known as the mask of pregnancy. And a line of darker pigmentation known as the lanea nigra often appears on the lower abdomen and extends from the umbilicus to the pubic bone. Y'all know that's that line down the center of the stomach, where from the umbilicus to the pubic. Everybody know that line. You had that line when you was pregnant before. So, if you've been pregnant before, so probable signs of pregnancy. Probable signs of pregnancy are so I just told you everything about the presumptive signs of pregnancy. Now let's talk about the probable signs of pregnancy. Probable signs of pregnancies are more objective than presumptive signs. They are more, they're more, so we can kind of see, see what's going on. They are more reliable indicators of pregnancy than the presumptive signs, but still are no proof that pregnancy exists. Basal, we're gonna um, test the basal blood temperature elevation. There's going to be a positive urine pregnancy test, cervical changes, vulvar and vaginal changes, uterine changes appear, and belatment changes or belatment, if I'm saying it right, and enlargement of the abdomen. These are all things that takes place for the probable signs of pregnancy. So basal body temperature elevation. So the body temperature at rest or basal body temperature BBT rises slightly. That's usually less than 1 degree as one of the earliest signs of pregnancy. For accuracy, however, comparison requires that the um, it requires also that the temperature also must have been recorded and taken before pregnancy. So it got to be before and after for us to just say, oh, yeah, she's pregnant. Possible urine test, possible urine test that's going to be um, that hormone, the HCG, or you can call it the human chorionic gonadotropin. That means if that is increased, the pregnancy test is going to come out positive. So the hormone is produced by the cells that becomes the placenta. I would know that. It can be found in small amounts in a woman's urine or blood by about the 7th to 10th day of pregnancy. The manufacturers of home pregnancy tests recommends confirmation of results through professional examination and clinical testing. So don't just solely rely on the home pregnancy test. You need to go in and get a professional exam and clinical testing to verify that you are pregnant. The most common error is a false negative, meaning results from urine tests that is performed too early to obtain an accurate finding. Okay. All right. So cervical changes at about 8 weeks of gestation, the cervix softens. The cervix is going to be softened. It's going to soften at about 8 weeks of gestation. This is known as the Goodell sign or the Goodell sign. Goodell sign. Before pregnancy, the cervix feels firm, like the tip of a nose. During pregnancy, it it feels more. It feels softer more than the earlobe. Okay, so like I said, before pregnancy, the cervix feels firm. During pregnancy, it feels softer. Before pregnancy, the cervix feels firm. During pregnancy, it's soft, like an earlobe. The cervix also looks blue or purple when examined. This is a Chadwick sign and may occur as early as the 6th week of pregnancy. And when I see the word Chadwick, I'm thinking about blue and purple. I'm thinking about those colors in um, Chadwick Boseman in what's the name of that movie? The Black Panther, how you had the blue and the purple colors, and Chadwick was he was the Black Panther. So and Wakanda had all those different type of colors, blue and purple. So just when you see Chadwick, think about Wakanda, think about those blue and purple um, colors in the movie Black Panther. So that is where you come from. That is how you can remember the cervix color, the blue and purple, due to Chadwick, and that's the Chadwick sign. And Chadwick is the actual guy who, the guy who died of cancer, the Black Panther. But anyway, vulvar and vaginal changes, the blueness due to increased blood supply, that which is the Chadwick sign, also occurs on the vulva and vagina. So it's not only going to occur on the cervix, it's going to also occur on the vulva and the vagina. At about 6 weeks, the lower uterine segments, that's the portion between the body of the uterus and the cervix, softens. At about 6 weeks, the lower uterine segment softens at about 6 weeks. This is called the Heger sign. The Heger sign. So that's at about 6 weeks, the lower uterine segment is going to soften, and that is Heger. Heger is the soft ass motherfucker. Hager is soft. Hager is soft as hell. And he been that way for about 6 weeks. He a soft ass nigga. Hager is soft, and he's been that way for about 6 weeks. So the lower uterine segment, Hager sign, it's a softening. Okay. So the softening of the uterine fundus, where the embryo has implanted, also occurs by about the 7th week. The softening of the uterine fundus, where the embryo has implanted, also occurs about the 7th week. The fundus enlarges by the 8th week. The uterus as a whole enlarges steadily throughout the pregnancy. The uterus rises above the symphysis pubis by the 12th week and reaches the umbilicus between the 24th and the the 20th and 24th week. I don't think we need to know any of that, but if we did, that's what I would remember. Belatment, belatement. After about 16 to 18 weeks of pregnancy, gently tapping on the side of the pregnant woman's abdomen will cause that fetus to bounce the ass. Okay, fetus is bouncing its ass due to ballet. Think of a ballet dancer bouncing all over the damn place. So about 16 to 18 weeks, if you hit the side of that, well, not hit, but tap the side of that woman's abdomen, that pregnant woman abdomen, you're gonna feel that fetus bouncing his ass in that amniotic fluid, because the fetus is small compared with the amount of fluid. Examiners can feel this rebound tap, known as belatment, against their hands. So we can feel that. That's why we would say this is a more probable sign of a pregnancy during the 16 to 18 weeks. So, also enlargement of the abdomen. So, as the uterus increases in size, the abdomen is forced outward. So, of course, you know that a woman is pregnant when her abdomen starts to grow. Now, let's talk about the positive signs of pregnancy. This is how we know for sure, it is a baby up in that thing. So it's going to be due to the visualization of the fetus, because we see it with the ultrasound, or less likely on the X-ray, but it's mainly that ultrasound is going to let us know it's a baby up in there. And you can see that as early as the 4th week of gestation. And ultrasound examination is safe, painless, and relatively inexpensive. Then you got the fetal heartbeat for a positive sign of fetus. We can use either a Doppler and also a fetoscope, um, which is a special manual stethoscope. The fetoscope is, and we know what a Doppler is when you can't check a person's blood pressure with the blood pressure um, cuff, we use a Doppler. So the Doppler is an electronic stethoscope, converts ultrasonic frequencies, high frequency sound waves into audible frequencies or onto a video monitor. And the examiner can hear fetal heart tones with the Doppler as early as the 10th week, as early as the 10th week. So I will put that, I will highlight that. That's with the Doppler. With the Doppler, we can hear that. With the fetal scope, we're going to hear it about 18th to 20 in the 18th to 20th week. 18th to 20th week. We're going to hit it a little bit later with the fetal scope. A normal fetal heart rate ranges from, and we need to know this, 160 beats per minute, well, 120 to 160 beats per minute. When assessing fetal heart rate, the examiner must be aware of two other sounds to avoid confusion. That is the phonic souffle and also the uterine or placental souffle. Now, with the phonic souffle, it is a swishing sound produced by the pulsation of the blood as it is propelled through the umbilical cord. The phonic. So know that the phonic is the fetal heart rate. It is the same as the fetal heart rate. Phonocyphal, same as the fetal heart rate. Phonic, fetal, phonic, fetal. And phonic cycle is a swishing sound produced by the pulsation of the blood as it is propelled through the umbilical cord. It is its rate is the same as the fetal heart rate. Phonic, cycle, fetal, phonic, fetal, phonic, fetal. The uterine or the placental cycle is a swishing sound produced by the maternal blood as it flows through the large vessel of the uterus. The uterine is a swishing sound produced by the maternal blood as it flows through the large vessels of the uterus, and its rate is same as the woman's heart rate. So the uterine, same as the woman's heart rate. The uterine cycle is going to be the same as the woman's heart rate. So what the examiner needs to do is, who's ever listening, you're going to have to place your finger over the woman's radial pulse. You're going to have to feel it at the same time he or she is checking the fetal heart rate to avoid confusing the two. Now, the fetal heart tones should be evaluated at every every prenatal visit and at very frequent intervals during pregnancy. Nursing alert: if you are able to hear fetal heart tones, well, if you are unable to hear fetal heart tones, you got to let somebody, must notify somebody AS motherfucking AP. um well, the physician or nurse midwife or the nurse practitioner immediately. Now let's talk about the fetal movement by an examiner. We we said that was quickening. Well, that's what the mother feels. So an examiner may be able to feel fetal movement after about 20 weeks. These fetal movements must be differentiated from other movements within the body, such as peristalsis. So we can feel that baby moving around at about 20. Important changes in maternal anatomy and physiology. So the placenta, it produces so many hormones and in such great quantity that some people think of it as the hormone factory. The placenta, they think that's the hormone factory. And these hormones are needed to help the mother sustain the pregnancy, to nourish the rapid developing fetus, to prepare for breastfeeding, lactation, and for the mother to still have enough energy to support herself. Now, a key concept to remember is hormones and the size of the growing fetus both results in changes in the woman's body. Thus, the hormones and the size of the growing fetus both result in the changes in the woman's body. External changes. After the first trimester of pregnancy, most women look pregnant. After that first trimester of pregnancy, most women, um, most women look pregnant. Their abdomen changes and contour, becoming increasingly more round as the pregnancy progresses. As the abdomen enlarges and her center of gravity shifts forward, the woman posture and gait alter as well. So she shouldn't be wearing high heel shoes and she shouldn't be climbing ladders and shit. So after the first trimester of pregnancy, most women look pregnancy. The abdomen changes in contour, becoming increasingly more round as pregnancy progresses. Okay. And she develops an inward curve. We know that as lordosis. Lordosis. And during late pregnancy, her rib cage flares out, so it can have making room for the fetus. Internal changes, this is what's going on the inside. This is external changes we see in the woman. Now, internal changes, that's going to be in addition to the visible changes of pregnancy. A woman's body experiences tremendous internal changes. So the hormones of pregnancy cause these changes, which are designed to support the pregnancy and the developing fetus. So just know that hormonal changes is what goes on with the internal changes. Now, as far as hormonal levels or hormone levels, important hormones of pregnancy include progesterone, estrogen, ACG, and HPL, which is the human placental lactogen. Levels of estrogen and progesterone rise steadily from early pregnancy until close term, when the when they when they level off, and then they may decline slowly. A similar pattern is true to HPL, except that it is not produced until close to the beginning of the second trimester. This HPL is going to come about, close to the second trimester, and then uh, it rises rapidly until about 34 weeks. Then it decreases, and then on the other hand, ACG, as is the primary hormone, what is the primary hormone of early pregnancy, it is its levels drop significantly during the second trimester. Some of the most important hormonal effects include maintaining the endometrium so that the embryo can implant. Um, so let me slow down. This is some of the most important hormonal effects include maintaining the endometrium so that the embryo can implant, causing changes in the mother's metabolism so the nutrients will be available for her own needs as well as the needs of the growing fetus, causing an increase in the mother's blood volume and red blood cells mass to provide the extra oxygen needed for both the fetus and her own increased demands, increasing the supply, increasing the blood supply to the GI tract, and slowing the peristaltic waves changes that result in increased absorption of nutrients, relaxing the ligaments that connect the pelvic bone, allowing them to spread slightly to increase the space available for the fetus to pass through. And lastly, preparing breast for lactation while keeping the milk from coming in until after the baby is born. And these are all important hormonal effects, um, you know, that's included. And I will remember those. And then anticipatory guidance above changes with the anticipatory guidance above changes. So just know that anticipatory guidance is a term that means education about expected changes. That's what anticipate. So basically, anticipate. We anticipate that these changes are going to happen before their occurrence. So, example, anticipatory guidance um, uh, about pregnancy changes includes a woman should not have bleeding during pregnancy, and she should tell her provider promptly if she does. Note that some women have a spot or two when implantation occurs, just about the time they expect a period. However, you should inform the physician, nurse, midwife, or nurse practitioner about any bleeding that a pregnant woman reports. A pregnant woman may wake up feeling very hungry. So you're going to tell her to eat a starchy food, such as a baked potato, just before bedtime. She should avoid eating a lot of sweets because she can have a rapid rise in the blood sugar and then followed by a sharp drop. Either of these changes can cause uncomfortable symptoms. Advise her to try to avoid consuming concentrated sweets to prevent this from occurring. As her blood volume rises, the pregnant woman's heart has to pump a little bit harder and it's pumping more stronger to deal with the increased workload. She may feel palpitation or rapid and pounding heartbeats. That's normal, but it's not normal if she feels dizzy or lightheaded. The extra blood flow that forms in the GI system, along with the slowing peristalsis, may combine to cause constipation and hemorrhoids. So that pregnant woman needs to consume plenty of fiber and water to prevent that from happening. Also, as the ligaments relax and the pregnant woman's centers of gravity changes, her balance may be off. So that's why I said she doesn't need to wear high heels, and especially during pregnancy. She doesn't need to wear high heels. Doesn't need to be climbing on a ladder. And breast enlargement is normal. Big titties is normal during pregnancy. So the pregnant woman may need to buy a larger bra size, and she also, not only is it for the cup size, but it's also for the chest because the ribs are expanding. So that is normal. So these are danger signs. I put that before actually putting what the danger signs are. So let's go over the danger signs. So, and then we're going to read about the signs of possible problems during pregnancy. So the danger signs. So you got the pregnancy danger signs. In the first trimester, excessive vomiting. We know that is hyperemesis, um, gravidarum, at any time during pregnancy, if that client has vaginal bleeding, excessive or irritating vaginal discharge, dizziness or fainting, decrease in urine output, burning with urination, persistent vomiting, chills or fever, and chest pain, that is a pregnancy danger sign. And another pregnancy danger sign is late in pregnancy. There's leaking or gushing of amniotic fluid, swelling in the woman's extremities or her face, dyspnea, blurred vision, or spots before the eyes, severe headaches, abdominal, epigastric, or severe back pain, decreased fetal movement, and lower abdominal pressure. These are all late in pregnancy for pregnancy danger signs. So I would definitely know all of that. All right. So signs of possible problems during pregnancy. So danger signs during the first trimester. We'll take a break. Okay, for the signs of possible problems during pregnancy, I already told you what the signs were in the first trimester at any time during pregnancy and late in the pregnancy. So, signs of possible problems during pregnancy, danger signs during the first trimester. So, the primary danger of the first trimester is a spontaneous abortion. Signs of threatened abortion include vaginal bleeding or spotting. This bleeding does not mean that the woman will miscarry, but it does indicate that she might do so. So, bleeding due to a threatened abortion reflects a partial separation of the placenta from the decidua. Blood may appear bright red, darker red, or brown. The amount of blood lost does not predict the outcome. Then we have vaginal, I ain't gonna worry about it. Vaginal or lower abdominal pressure. This may occur when the cervix is incomplete or not strong enough to hold the fetus inside the uterus. This symptom is especially worrisome if the woman also has increased but vaginal discharge. That is vaginal or lower abdominal pressure. Then PTL. I forgot what PTL stand for. I'll get you some. Give me a second. PTL. Hold on, I'm in my book looking for it. Hold on, where is the PTL at? Oh, PTL. That is that's going to be pelvic abdominal cramping. No, that ain't. PTL stand for preterm labor. Let me type that up. Preterm labor. That's what it stands for, aka PTL, preterm labor. And early signs include backaches, pelvic abdominal cramping, rhythmic pelvic pressure, diarrhea, change in vaginal discharge, vaginal spotting, leaking fluid, and malaise. That's what preterm labor early signs are. And then PPROM or PROM, that stands for um, premature labor or premature rupture of the membrane. Premature rupture of the membrane. Let me type that up. Premature rupture of the membrane. Uh-uh. So this condition with the the PROM, the PROM, or the premature rupture of the membrane, this condition may cause either a gush of fluids or a continuous steady trickle of fluid. The gush is usually easily recognized by the woman, may not realize, but the woman may not realize that a slow, steady leak is a problem. A slow, steady leak is definitely a problem. So decreased fetal movement. So regular fetal movement is a sign of fetal well-being, but when it's decreased, um, activity is a cause of a concern. A decreased activity or a marked drop off in the fetus activity is a cause of concern about the health of the fetus. The following may be a sign of PIH, which is bring that over, that over, and that over. That includes severe headaches, which does not respond to um, over the counter remedies, visual problems, vision, sudden blurry, sudden blurred vision, seeing spots or flashes, flashing lights, sudden edema or swelling, especially of the face, eyes, and hands, epigastric pain, or pain in the upper abdomen. Now let's talk about the health care during pregnancy. The prenatal, and okay, so this is everything that we need to know. I think I would try to remember that. I think that's important to know too about these. So, healthcare during pregnancy, the prenatal period refers to, let me see what that what is it? PIH. Let me see what this stands for. It don't say. If y'all know what PIH stands for, please type it. If you listen to this video, type it in the comments. Okay, so healthcare during pregnancy. Healthcare during pregnancy, the prenatal period refers to period between conception and the onset of labor. That's the prenatal period. It's going to refer to the period between conception and onset of the labor. The goals of good prenatal care are to promote physical and mental wellness of the mother during the pregnancy and afterwards, help the woman give birth safely and without complication, ensure a healthy baby. Regular prenatal care is associated with lower infant mortality and becomes well and better outcome on measure of child health, such as weight. So that is the goal of prenatal care or to promote physical and mental wellness of the mother during the pregnancy and afterwards, help the woman give birth safely and without complication, ensure a healthy baby. Regular prenatal care is associated with lower infant mortality and better outcomes on measures of child health, such as the weight. Now, with special consideration, that's culture and ethnicity. Prenatal care, although Japanese American women are expected to go for prenatal care from early in pregnancy, Roma women often avoid prenatal care to avoid having an internal pelvic examination. A different attitude is traditional among Mexican Americans who may believe that pregnancy is not an illness, so prenatal care is unnecessary. Others within that culture seek prenatal care for reassurance of fetal well being. Some Mexican American women view prenatal care as a formal home care received from a family member. And then, um, hold on. And then for uh, the special consideration, culture and ethnicity. uh, Um, that's belief about pregnancy. So traditionally, Ethiopians and Eritreans view pregnancy as a dangerous state. The fetus is easy prey for the evil eye and sorcery, which are believed to cause miscarriage, premature delivery, and a fetal malformation. For Samoans, pregnancy is considered an illness. Pregnant women cannot eat alone or be left unattended, especially at night. In Puerto Rican families, pregnancy is a time of indulgence for women, whereas in Southeast Asia cultures, pregnancy is considered a healthy state. So everybody got their own little beliefs about what exactly pregnancy is. We might need to know that. I'm not for sure. I'll look at it a couple of times to just keep it in my head. Now, when we talk about choosing a healthcare provider, okay, so right here we're trying to choose a healthcare provider. So, choosing a healthcare provider, a woman may choose a choose a physician, a nurse midwife, or a nurse practitioner for her prenatal care. For example of question, well, some examples of question a woman might ask as she selects a prenatal care provider includes: do I want a male or female provider? Should my provider speak the same native language? And all this other shit that you can look at. So components of prenatal care. With the components of prenatal care, there are three basic components of adequate prenatal care. I'm gonna make that back black and keep that pink. Okay, early. So three. So there are three basic components of adequate prenatal care. You got early and regular prenatal care, maintenance of maternal health, promotion of good health habits, and then recognition and treatment of physical, mental, and social economic problems. The risk assessment. For risk assessments, the goal of risk assessment um, is to identify women and fetuses who have a chance of having a complication during pregnancy, labor, birth, or the neonatal period. There is no perfect risk assessment system. There is no perfect risk assessment system. The best health for mother and baby results when the mother has her first visit before the end of the first trimester, that's before the end of the 13 weeks, and then has regular visits until after she has delivered the baby. The results, well, the usual timing for visits is about once every 4 weeks for the first 28 weeks, and then it's going to be every 2 weeks until 36 weeks, and then weekly until birth. So I would know that. So every 4 weeks, you're going to have one visit for the first 28 weeks. And then when we get to the 36 weeks, it's going to be every 2 weeks. Then every 30, well, then 2 weeks until the 36th week, it's going to be then every 2 weeks until 36 weeks. So 28 weeks is going to be once a month. Then when I get close to the 36 weeks, well, after the 28 weeks, I'm going to do it every 2 weeks. And then when I get um, after 36 weeks, it's going to be once a week. The postpartum visit is usually scheduled at 4 or 6 weeks after birth, although many providers um, see women like at 2 weeks postpartum. The initial prenatal visits, the following are key components of the initial prenatal visits. So you got health history. With the health history, the providers takes a complete health history of the woman and her partner, if possible, to learn about past illnesses and any patterns of certain inherited diseases that might affect this pregnancy. So that's like sickle cell and diabetes and Tay Sachs. The provider is also interested in learning whether a multi-fetal pregnancy, meaning if she had, if there's twins in the family, in either family, the male or the female. The physician, nurse midwife, or nurse practitioner needs to know if the woman has had any difficulties during pregnancy or birth, or if she has had any serious infection like STDs or HIV. It is also important to assess the woman's lifestyle, including risk due to infection, substance use, or domestic violence. And then pelvic examination, I'm sorry, physical examination. For physical examination, of course, it's going to include a pelvic, but a complete physical exam, including a pelvic exam, is part of the initial prenatal visit. This head to toe assessment includes examination of the gums, the teeth, the thyroid glands, heart, lungs, breast, and all body systems. Also, the woman's height and weight should be measured and recorded at the first prenatal visit. During the pelvic examination, the provider checks the reproductive organs and signs of pregnancy, the bony pelvis for approximate size and shape, and looks for indication of any health problems. Pelvic measurement helps in determining whether the um, the passageway, the bony passageway is large enough for delivery of a normal sized newborn, and especially important consideration in a prima gravida. That means this is her first pregnancy. A pap test and STI tests like gonorrhea and chlamydia are also routinely performed as part of the pelvic examination. Lab tests, the woman's blood and RH factor are determined. If the woman is RH negative, she should receive ROD, RHOD, immune globulin, Rogam, Gumilin RH at the 28 week of gestation and following any episodes of bleeding or any invasive procedure. The purpose of giving the Rogam is to prevent RH isoimmunization. Okay. Other blood tests, other blood tests that are routinely obtained includes a syphilis test, that's RPR and BDRL. Also, a complete blood count, antibody screen, and rubella titer. As I stated earlier, a rubella titer is done to determine if the woman is immune to rubella or German measles. If she is not vaccinated during pregnancy because of the rubella vaccine is live and could possibly have a harmful effect on the fetus. And then HIV testing should be offered to every pregnant woman, according to the Institute of Medicine and American College of OB and gynecologists. If a woman tests positive for the virus and begins treatments for HIV during the pregnancy, the risk of transmitting the virus to the fetus drops significantly. In addition to the woman's, well, in addition to the pregnancy test, if it is needed to confirm the pregnancy, the woman's urine is tested for albumin protein. We're going to also test it for glucose and presence of harmful bacteria. Each time a urine sample is collected, it's going to be done with the clean catch specimen. The pregnant woman should be given a tuberculosis test. So that's the Mantoux tuberculosis skin test, TES, because we're just trying to test for tuberculosis and we know how to do that. Um, this is the nursing alert. The TST contains zero point 0.1 tuberculin, purified protein derivative PPD given intradermally into the inner surface of the forearm. We know how that goes. We know how that goes. We know everything about that. But let me go on and finish reading it. So, a specific TB syringe must be used with the needle bevel facing upwards. Correct procedures of administration and reading are necessary. The TST must be read between 48 72 hours. In reading the test, only the raised area, not the reddened area, must be measured. A normal response may produce a pale elevation or wheel of 6 to 10 millimeters in diameter. Redness is not measured. So that's everything you need to know about the TB. But we know how TB go. We always get TBs. So if the woman or the baby fathers has a family history of genetic problems, a referral for genetic counseling and testing should be given to the couple. Determining the baby's due date. A woman, I'm gonna highlight that because I think that's important to know. A woman who thinks she is pregnant is wise to consult a healthcare provider after she has missed one menstrual period. A full term pregnancy is approximately 280 days from the first day of the last menstrual period. That's a full term pregnancy. It's going to be about 280 days from the first day of the last menstrual period, or 266 days after fertilization. The 280 days equals 40 weeks. So many women do not keep an accurate record of their menstrual periods or may not have regular periods for many different reasons. In these cases, the practitioner determines um, the estimated EDD, which is the estimated date of delivery or estimated date of confinement, based on the size of the uterus during the physical examination and or by an ultrasound estimate of fetal age. Okay, so based on the size of the uterus, if she doesn't know, or if she have menstrual problems, so we're going to do this by um, based on the size of the uterus during the physical exam and by an ultrasound estimate of fetal age. The actual duration of pregnancy varies greatly, and the EDD is an approximate due date. Only about 4% of women actually deliver on the actual due date. Initial risk assessment, the provider determines the degree of risk to the woman and fetus based on info from the history, physical exam, lab result, and due date. That's for the initial risk assessment. So the provider determines the degree of risk to the woman and fetus based on information from the history, physical exam, lab results, and due date. Based on her risk assessments and individualized plan of counseling, classes, referrals, and prenatal care appointments is developed with the pregnant woman. Return prenatal visits. So at each return appointment, also called a revisit, the following measures should be performed and charted by a member of the healthcare team. So weight, blood pressure, urine, uterus, fetal heart tones, edema, and continuing risk assessments. This is all what should be uh, performed and charted by a healthcare team. So with the weight, um, we want to compare the weight from the pre-pregnancy weight into the previous weight measurements. We want to do blood pressure. Sometimes blood pressure goes up or down, it fluctuates. We're going to test the urine, make sure there's no protein with, an excessive amount of protein or glucose in the urine. It's such, sometimes nitrates and leukocytes, and that may indicate a blood infection. So that's why we test the urine with a dipstick. The uterus, we're trying to measure the size of the uterus, and it's called fundal height. And an evaluation of its growth since the last visits are performed. So that's why we um, look at the uterus or measure the uterus. We want to listen to the fetal heart tones. Like I said, fetal heart tones are between 120 and 160. That's the normal range. And then we want to look at any edema because that could be preeclampsia. That's what I had. So my face was swollen, my hands, my legs, and my feet. Everything was swollen up. So we want to check the face, hands, legs, and feet for edema. And that could mess with the blood pressure. And then also continuing risk assessment at each prenatal visit, the risk problems should be updated. If new information indicates a change in the woman's risk status, the provider will develop a new plan of care with her to address her needs. So we're right here, Nagel report, Nagel rule determining the anticipated date of birth or due date. Excuse me. Now I read this already. It's somewhere up here somewhere, but let's read it again because it's in this chart. And if it's in the data gathering chart, I think we should know it. This is data gathering in nursing 65-2. This is from the new book. So, pregnancy is dated from the first day of the woman's last normal menstrual period to be considered normal. The period should have come on time, lasted as long as it is usual for her, and have been the normal flow for her. Now, if none of that take place, we need to see if this lady is pregnant or not. So, any of these three items is not true of that period. Ask her to recall the first day of her previous menstrual period. So that's PMP. When you have an accurate date for her last period, the due date for the baby is determined either by using the gestational wheel or by applying Nature rule. Um, and the due date is usually called the estimated date of confinement or EDD, which is the estimated date of delivery. NAGA rule, it says determine the date of the first day of the woman's last normal menstrual period. So you got to determine the date of the first day of the woman's last normal menstrual period. Then you're going to add 7 days on to that, and then subtract 3 months. The result date is the EDD, where the resulting date is the EDD. So, initial risk assessment, the provider determines the degree of risk to the woman and fetus based on information from the history, physical exam, lab tests, and due date. Commonly used terms for risk status or low risk and high risk, although there is certainty such as so either the lady is going to be a low risk pregnancy or high risk pregnancy. So, although there is certainty, such as things as moderate risk, it is very hard to define. Based on her risk assessment, an individualized plan of counseling, classes, referrals, and prenatal care appointments is developed with the pregnant woman. So, moving on, we're talking about additional tests performed during pregnancy. Many women have an ultrasound examination done between 16 and 20 weeks. This is very accurate time at um, which to determine gestational age and also to examine the fetus for normal development. If there is a problem or a concern at a different point during the pregnancy, the ultrasound examination may be repeated between weeks 15 and 19. A blood test called the maternal serum alpha fetoprotein, the MSAFP, is done. That's between the weeks of 15 and 19. A blood test called the maternal serum alpha fetoprotein MSAFP is done. The primary purpose of this test is to screen for fetal neural tube defects. So we're trying to check and see if this baby got Down syndrome or not. So we're going to combine that test with two other tests known as the ACG and the esterol, which increases the number of neural tube defects that may be identified and also screens for Down syndrome. I had this test done, um, and this test is called a triple marker screen. Triple marker screen. When you get the MSAFP, the ACG, and estriol, that's going to be the triple marker screen. Between 24 and 28 weeks, all pregnant women should be screened for diabetes. I think that's important to know. I think that's important to know. So between 24 and 28 weeks, all women, all pregnant women should be screened for diabetes. So a test used during pregnancy is a 1 hour random glucose tolerance. A test used during pregnancy is a 1 hour random glucose tolerance. And a woman eats normally until her prenatal or lab appointment, and then she's going to drink 50 grams of glucose beverage. Her blood is drawn 1 hour later to be tested for glucose. Elevated glucose levels may indicate gestational diabetes. The Rh antibody, which is repeated 26 to 27 weeks, the Rh antibody test is repeated at 26 to 27 weeks, and RhoGAM is given at 28 weeks if the antibody test remains negative. Many providers repeat STI testing at 36 weeks and may also do a vaginal culture for group B streptococcus. Okay, so like I said, many providers repeat STI tests at 36 weeks and may also do a vaginal culture for groups B streptococcus. So this is the important medications for the RH immune globulin ROGAM. I don't think we need to know it, but I would definitely go over it as far as the expected effects and the adverse side effects and the nursing consideration. And ROGAM should also be given. So okay, before I do that, I would definitely go over that. But and let me highlight what I would go over. Okay, what my highlighter? It's my highlighter. And let me show y'all what I go over. So, uh, okay, so right here, I wouldn't go over that. It's just talking about microdose 50 milligrams used after spontaneous or selective abortion at less than 13 weeks gestation. I don't know about that. If you want to look at it, look at it. So full dose 300 at 28 weeks gestation. Expected effects in RH negative woman. Rogan prevents antibodies to prevent. So I would look at this. So expected effects in an RH negative woman. Rogan prevents antibodies to RH positive female. Well, I'm sorry, RH positive fetal blood cells from forming. The 28-week dose provides protection for about 12 weeks. Another dose should be given after delivery. And I will know this for Rogan. Adverse side effects, I would know those. There's going to be pain, soreness at injection site, and nursing consideration. I would definitely know that because we're the nurses, right? So we need to know that. So ROGAM should also be given if an RH negative woman has any bleeding during the prenatal period or if she has invasive testing performed, such as chorionic villus sampling or an amniocentesis. ROGAM is a blood product, but unlike whole blood or red blood cells, it is a processed immunoglobulin, globulin, and it is safe for pregnant women to use. So the method of its preparation includes viral activation. So HIV is not a concern with this blood product because ROGAM is a blood product. Women who do not take blood products for religious reasons may refuse to take it because ROGAM, it is a blood product. Like Jehovah Witness or the women that don't get blood, they don't due to religious. I know it's who don't take blood, it's Jehovah's Witness. And women who do not take blood products for religious reasons may refuse to take it. Then we got health promotions. So with the health promotions, right? Okay. Elimination of hygiene. So a bowel movement is preferable for pregnant women, although not all women normally have one. A woman who has a tendency towards constipation may face increased um, difficulties during pregnancy due to increased peristalsis. Plenty of water, fruits, vegetables, moderate exercise, and adequate fiber intake encourage regular elimination. The body's oil and sweat glands are more active than usual during pregnancy. So, a daily warm, not hot bath or shower is important. No proof exists that a tub bath is harmful at any time during pregnancy. Um, of course, the woman must be careful not to slip or fall in the bathtub. But during the few weeks of pregnancy, a woman should not take a bath because her big ass ain't gonna be able to get up, especially if she home alone. And then just don't take one period because don't nobody want to try to get your heavy ass up out there tub. So, um, because you need assistance. So the woman hair may become oily well, oilier than usual, just due to the sebaceous glands. What it said that again? The body and sweat glands. That's the same thing, sebaceous glands. You're just sweating a lot. So the woman's hair is oilier, her skin is oilier than usual, and may need frequent shampooing. A woman may safely use hair coloring and permanent waving during pregnancy. So I don't know if y'all ever heard. I think in the black community they say don't put perms on your hair. I think I've heard that in the past, like, "Ooh, don't get them perms, it's dangerous," or whatever. So right here it says it's not dangerous. So all this shit we've been hearing throughout our life is kept. So the pregnant woman should practice good oral hygiene. Make sure she shouldn't have no funky ass breath and not brushing her damn teeth. Okay. So the same way she got that man with fresh breath, her breath need to be clean afterwards. The woman who eats a balanced diet and sees her dentist regularly does not need to worry about tooth damage during pregnancy. Necessary dental should be performed and sources of infection should be treated. Like for me, let me tell you, say many tests do not want to perform oral surgery like a root canal on pregnant women unless it is an emergency. Like for me, I had to get a tooth pulled, and it was a motherfucking emergency because when you get pregnant, everything is sensitive. And oh, I had the worst toothache in the fucking world. So, but many dentists they do not want to perform unless that shit is emergency. My tooth was a damn emergency. Okay, that shit hurt us. Oh, that shit hurted me so bad. Okay, so some women experience an increased salivation, with salivation called hytialism, just an increased salivation during pregnancy. Although annoying to the woman, hytialism does not cause tooth decay or gum irritation. Some women are advised by non professional sources, such as mothers or aunts, to dish during pregnancy. Please don't dish during pregnancy. Pregnant women should be advised not to dish. Do not listen to your mama, your aunt, and them, your grandma. They don't know what the fuck they talking about, especially if they're not a nurse. Okay, so don't dish because it can give your ass a vaginal infection. So fuck you dishing for anyway. Just go in there and rinse your shit out with some water. No dishing. Breast care. Breast care is important because you got them big ass titties now, right? So, except for the use of supportive bra, elaborate breast care is necessary before breastfeeding. Studies show that complicated nipple preparation barely makes a difference in successful breastfeeding. A woman who is considering breastfeeding may decide against it if she is presented with a list of nipple exercises and special creams and ointments she is required to purchase. Women who plan to breastfeed should bathe as usual and use little or no soap on the nipples. They should gently pat their nipples dry. The nipple secretes its own natural moisturizer, which should not be removed with soap or other chemicals. So don't use no soap or no shit like that. Just use water. Don't use no soap on your nipples. Just use water. Women should also avoid applying alcohol tinctures or benzos and lanolin ointments. So don't put nothing on your nipples. Don't put nothing on them big ass symbols because them bitches big. You know those areolas get big and shit. So don't put nothing on those. So these substances may damage the areola and nipple and have not been shown to be effective in preventing sores and cracked nipples. So don't do that shit. If your mom and them and grandma and them told you to do that, that's cap. So lanolin is also a common allergen and may contain intesticide residual in DDT. So don't put that shit on your nipples. Okay, so wearing a nursing bra with the flaps down and exposing the nipple to air and sunshine may help to condition them. So if you got a back patio, go out there and if ain't nobody looking or snooping on you, let them nipples out and let that sunlight hit them damn nipples. Harsh treatments may cause sores and cracked nipples and should be avoided. Nipple exercises and stimulation should not be done, especially in the third trimester when they can cause uterine contraction and premature labor. Flat nipples should be treated with breast shields that are worn during the last trimester and after delivery between feeding. Inverted nipples are rare and can be treated with a nipple shield. Okay. So wearing a nursing bra, flaps down and exposing nipples to air and sunshine may help to condition them. Harsh treatment may make that shit sore and crack. That should be avoided. That's like putting that soap on there and all the other shit they told you not to put on there. Nipple exercises and stimulation should be done, especially in the third trimester when they cause uterine contraction and premature labor. Flat nipples should be treated with breast shields that are worn during the last trimester and after delivery between feedings. Rest. Make sure you get some good ass rest. The pregnant woman uh, tires more easily and should have enough rest to avoid fatigue. Preventing fatigue is better than having to recover from it. So the woman should know how much rest she ordinarily requires and plans to get more if needed. Going to bed earlier, getting up earlier, or taking an afternoon nap may help. Short daytime rest periods are beneficial if the woman really relaxes. Pregnant women are able to correct, well, pregnant women are able to carry normal household activities without harm if they avoid heavy work and get additional rest. As pregnancy advances, the woman may have a hard time finding a comfortable sleeping posture. Simple measures such as additional pillows at the back or a pillow supporting the weight of the abdomen or the top arm while the woman lies on her side will usually relieve these common problems. During the pregnancy last months, the woman should rest on her left side for at least 1 hour in the morning and afternoon. This position relieves fetal pressure on the renal veins, and it helps the kidneys excrete fluids and increase flow of oxygenated blood to the fetus. Advise the pregnant woman to not sleep or lie on her back to avoid supine hypotension syndrome, which is orthocable compression. So she shouldn't lie on her back at all. She should not sleep or lie on her back to avoid supine hypotension syndrome. Um, the weight of the uterus can interfere with the circulation in the aorta and the vena cava, thus depriving the woman and the fetus of oxygen. If the woman must remain on her back, place a small pillow or towel roll under under one hip. The goal is to keep the woman's circulation unimpeded by displacing the weight of the uterus to the side rather than on the major blood vessels. So this is what it looks like. Let's say this is her left side. She should lay on her left side. She should lay on her left side. And this is the aorta, vena cava, with the aorta, the vena cava, the lumbar, with the lumbar right here, lumbar vertebra. You got the aorta right here and the vena cava. So just know, hey, it says rest position during pregnancy. The knees and elbows should be the knees and elbows should be slightly bent, the muscle limps, and the breathing slow and regular. Notice that the weight of the fetus is resting on the bed. Supine hypertension syndrome can occur if a pregnant woman lies on her back. So do not lie on your back. That's what's going on if you lie on your back. And if a woman turns on her side, pressure is lifted off of the um, vena cava. See, so when you see, when you lie on your back, that's what's happening. That's that pressure on there. Then when you turn to the side, ain't no pressure on there. See, it's doing what it's supposed to do. Look at your fat ass lying back and a big ass baby on the aorta and the vena cava. All right, so exercises. We're exercising posture. So exercise improves circulation, appetite, and digestion. As we know, it also aids in elimination and helps the woman to sleep better. The woman may safely continue customary exercise. So that's like swimming in a pool can be beneficial. However, swimming in the lake in later stages of pregnancy is not advised because of the danger infections. So do not go get your ass in no lake. Do not go to Cypress Lake with your family trying to swim for the 4th of July and you pregnant. Don't do that. You can get a damn infection. Okay? Shit. Specific prenatal exercises are a part of childbirth education. Walking in fresh air is excellent. It's excellent exercise. Whatever the exercise, it should not be fatiguing. Exercise should be daily rather than sporadic. Exercise should be daily rather than sporadic. Activity. So, weight gain, stability, or loss involves the balance between energy sources, diet and stored fuel, and energy expenditure. Energy use in the is in this energy equation is the combination of basal metabolic rate, body heat production, and physical activity. And the average total additional energy calorie requirement is about 25 to 300 or 3,500 calories per day. Changes in in daily physical activity or individual leading either to an increase or a decrease in energy use throughout the pregnancy. So let me read that again. Changes in daily physical activity or individual and leading either to an increase or a decrease in energy used throughout the pregnancy. Special consideration to keep in mind this is talking about culture and ethnicity, activities, and exercise. So during pregnancy, traditionally, Puerto Rican families view exercise during pregnancy as inappropriate. According to Puerto Rican families, this shit is inappropriate. Contrast with the Haitian women who are not relieved from their responsibilities and are expected to fulfill their obligations throughout the pregnancy, and pregnant Cambodian women who are also active. So them Haitians and them Cambodian women, they can't sit their ass down for then. They got to work. Ain't no risk. Get your ass up there and work. Unfortunately, that's why them some strong ass women. So let's talk about these exercise guidelines during pregnancy. The goal of prenatal exercise is physical fitness within the limitation of pregnancy. If a woman does not have contraindication as designated by her healthcare provider to exercise to exercising during pregnancy, these general guidelines should be followed. Women with uncomplicated pregnancies can continue a moderate exercising program with these modifications. So reduce the intensity of exercise by about 25%. Let me highlight what I think is important. So this is women with uncomplicated pregnancies. Uncomplicated pregnancies can continue a moderate exercise program with these modifications. So reduce the intensity of the exercise by about 25%. Maximum maternal rate, well, maximum maternal heart rate should not exceed 140 uh, beats per minute. Periods of strenuous activities should be limited to 15 to 20 minutes inter intersperse oh shit intersperse it with low intensity exercise and rest periods. Extreme active women, like uh, extremely active women and athletes and women who perform vigorous aerobic exercise, should reduce the level of exertion. Sedentary women who are, yeah, sedentary, yeah, sedentary women, that's women sitting on their ass, should begin to exercise very gradually. The types of exercise that provide the best cardiovascular and psychological benefits throughout pregnancy are walking, cycling, and swimming. I would definitely know that. I would definitely know about the sedentary woman. Relaxation and stretching exercise like yoga may be continued throughout pregnancy. Muscle strengthening exercise such as Kegel exercise to prevent the pelvic floor and pelvic tilts or pelvic rocks to straighten the lower back and hold on. Muscle strengthening exercises such as Kegel exercise to strengthen the pelvic floor and pelvic tilts or pelvic rocks to straighten the lower back and relieve back pain may be done by all pregnant women. These provide no cardiovascular benefits. Jogging and weight bearing aerobic programs should be moderated to avoid injury causing ligaments relaxation and increase joint mobility during pregnancy. Women who lift weights may continue to lift light weights during pregnancy with the following modification. You want to avoid heavy resistance on machines, avoid use of heavy free weights, breathe properly to avoid the Valsalva maneuver. You want to sports that pose a potential risk to the mother or fetus include contact sports like football and soccer, sports involving potential joints or ligament damage like basketball, volleyball, gymnastics, downhill skiing, skating, and even horseback riding. Sports that are safe to continue during pregnancy, racket sports, tennis, racquetball, squash, avoid heat stress though, decrease intensity as pregnancy progresses. You can do golf, but may need to modify golf swinging, slow pitch, softball, avoid sliding into bases and blocking bases, um, cross country skiing. All of these are some safe sports that you continue during pregnancy. Avoid any strenuous exercises for in adverse conditions like extreme heat, high humidity, air pollution, and high altitudes. I would know that. And then exercise in pregnancy danger signs. So a pregnant woman who is exercising should be alert to the following signs and symptoms. If these occur, she should stop exercising and contact her healthcare provider. Pain of any kind, uterine contraction. I think all of that's important to know. Pain of any kind, uterine contraction occurring at intervals of fewer than 15 minutes, vaginal bleeding, leaking amniotic fluid, dizziness, faintness, shortness of breath, palpitation and tachycardia, persistent nausea, vomiting, back pain, pubic and hip pain, difficulty in walking, generalized edema, numbness in any part of the body, visual disturbances, decreased fetal movement. So all of that are exercise in pregnancy danger signs. Um, Moving on, let's talk about the sexual relations pregnancy. Although usually, okay, so pregnancy, although usually a result of sexual activity, is not viewed as a sexual state in our society. Although certain individuals may consider the sight of a pregnant woman beautiful and erotic, she may be seen as misshapen, awkward, and not particularly arousing. In the last decades of the 20th century, pregnancy has commonly been viewed as natural, sensual, and beautiful. Pregnancy is always a time of challenge to a relationship, both development, mentally, and sexually. The challenge can result in either crisis or growth. During pregnancy, a woman continues to have sexual needs. If the pregnant woman has a partner, the partner also continues to have sexual needs. Both partners have needs for fucking and closeness, which may differ from their sexual needs. Intimacy needs can be categorized into the following three categories. So this is sexual needs. This is the fucking and shit. So the sex drive or the libido usually changes during pregnancy, although the pattern of the change in libido is quite individual. So, in addition, the sexual response cycle is affected by pregnancy. These changes, combined with the change in anatomy and physiology during pregnancy, have varying effects on the relationship of a pregnant couple. Sexual needs may be met through sexual activity with a partner or masturbation. Some women experience spontaneous orgasm due to the increased pelvic blood supply during pregnancy. Ain't that something? I ain't had that shit. So pregnancy diminishes sexual desire in women and increase it in others. So everybody is different. Some women don't want no dick, some women do. Communication between the pregnant woman and her sexual partner needs to eliminate conflicts. Touching, give me a second. Touch needs. Pregnancy is a time of a heightened need for touch, which may be met partially by sexual expression, but which can also be met through non sexual touch, such as massage, caressing, or holding. That's just touch needs. And then comfort and reassurance needs. With comfort and reassurance needs, the needs of the body, what the need of the pregnant woman for comfort and reassurance is going to stem both from her changing body image and from the development process of pregnancy. These factors bring fears and concerns for the pregnant woman about safety for herself and the fetus, her desirability, and her need for continued and love and support. So you got sexual needs, touch needs, and comfort and reassurance needs. I'm a whole thug. I didn't need none of this shit. And then let me see. We got a little minute to go. We got a little minute to go. Right here. This is where we at now. So um, I'm gonna read this and I'm gonna take a break. So So, sexual safety during pregnancy. In general, expression of sexuality during pregnancy are quite safe. Sexual intercourse is often physically difficult and awkward late in the pregnancy, and couples may wish to experiment with a variety of position and sexual practices. Sexual intercourse during pregnancy is not harmful as long as it is not unduly comfortable and no high risk factors are present, like placental previa or preterm labor or ruptured membrane. Then you can fuck. But if you got any of that shit going on, you ain't fucking. And don't be swinging from the shower rods and shit. You know, no high risk factors. Also, and with nothing harmful. And uncomfortable. So, like I said, placental previa, preterm labor, or ruptured membrane, you ain't doing no fucking. There are a few exceptions to this rule, and these risks can be categorized by the causative factor. Categories of risks includes risk due to penetration. So women who experience bleeding during pregnancy should avoid vaginal penetration until the problem is diagnosed. So once again, women who experience bleeding during pregnancy should avoid vaginal penetration until the woman is diagnosed. Risk due to possible infection. Risk due to possible infection. There are two primary areas where infection is a risk with sexual activity: sex with a partner who has STIs, and sex after the rupture of membranes, which normally protects the fetus and placental from infection. That is risk due to possible infection. There are two primary areas where infection is a risk with sexual activity. That's if your nigga got an STI, or and if the sex after the rupture of the membrane, which normally protects the fetus and placental from infection. So, risk due to arousal for a woman at risk for preterm labor, sexual arousal, and accompanying increased engorgement of the pelvic organs might stimulate the initiation of labor. This is no proof that arousal increases the risk of spontaneous abortion. Sexual arousal may be used as term to initiate labor. At this point in the pregnancy, it is no longer a risk. And then risk due to orgasms. And let me read risk due to arousal again because I'm flashed out. So, risk due to arousal. For a woman at risk for preterm labor, sexual arousal, and the accompanying increased engorgement of the pelvic organs might stimulate the initiation of labor. There is no proof that arousal increases the risk of spontaneous abortion. Uh, Sexual arousal may be used as a term to initiate labor. At this point in the pregnancy, it is no longer a risk. Risk due to orgasm. Risk due to orgasm. So the uterine contraction that occur with the following orgasm may stimulate preterm labor. Damn. So risk due to orgasm, the uterine contraction that occur with the following orgasms may stimulate preterm labor. Ain't that some shit? And then you got risk due to sexual behaviors. With the exception of STIs, exposure, the main risky sexual practice during pregnancy is the forceful blowing of air into the vaginal, which may result in air embolism. So nobody should be blowing up your pussy hole. Um, and when you do it or whatever, air get up in there, so that may put you at risk for air embolism. Ain't that some shit? With the exception of STIs exposure, the main risky sexual practice during pregnancy is the forceful blowing of air into the vagina. Oh, there's somebody trying to blow your ass up like a goddamn balloon. No blowing on the pussy. So clothing. By about the third month, the pregnant woman will discover that her clothing is becoming tight. So she got these two ass clothes on and she needs to wear looser clothing. Some women wear special maternity clothes. Other women just put on their put on their man clothes or go to Goodwill, get some big ass loose fitting clothes. Oversized sweaters, elastic pants and skirts, garters, constrictive knee socks, and knee high pantyhose should not be used. Do not use that shit because they restrict the blood flow. Women should wear comfortable shoes. Flat heels are less awkward and provide a better base of support. So wear some flat ass shoes because your gait already fucked up. Gap, how you pronounce that word? The pregnant woman will probably have difficulty tying shoelaces or fastening, so you need to get you some damn Velcro shoes. The pregnant woman should wear a wide strapped bra that supports the breast without causing nipple pressure. No, so no too little ass bras. An underwire bra is usually more comfortable for the woman with heavy ass titties. That's me there. A good nursing bra is essential after delivery if the woman plans to nurse. She should purchase two or three bras of her normal chest size, but with a larger cup size. Breast and employment. I'm talking about breast and employment. Shit. Talking about the damn titties. So travel. Okay, so travel and employment. I hope y'all don't hear that damn loud ass TV. So travel and employment. Most women continue driving during pregnancy, at least until the last month when it may become uncomfortable. The fetus, woman, and steering wheel cannot occupy the same space at the same time. So the woman must be secure to be sure to buckle her seatbelt under her enlarging abdomen. She should use the shoulder strap, placing it on the side of her abdomen. Um, I think I got a picture. Did I put that picture in here? Oh damn! You can look in your book for the picture. I thought I included it, so look in your book for the picture. Seatbelts are particularly important during pregnancy to protect the woman and the fetus. A car with airbags provide add protect. They added protection. Long trips are exhausting for anyone, but because today's families are often on the move, the pregnant woman may find regular travel necessary. Travel by air or train is recommended for long, tiring trips. If the woman, so you're gonna do air or train for those long ass trips, for those long, tiring trips. If the woman is to travel by car, she should plan to stop at least every 2 hours to go to the bathroom, stretch, relax, and walk around for at least 10 minutes. This movement helps to prevent blood from pooling in the lower extremities. The, uh, the, The pregnant woman should never fly in a small plane that is not pressurized because the lower atmosphere pressure decreases the supply of oxygen to the fetus. Expectant women should consult with the healthcare provider about travel plans because special conditions and times during pregnancy may rule out traveling. A long so if you're about to get ready to have a baby close to term, you shouldn't be doing no traveling. So a long trip away from home when the woman is close to term is also unwise. Many women continue to work outside the home during pregnancy. The law states that in most situations, a pregnant with a maternity leave of absence without loss of seniority must be granted to women to a woman who requests one. Jobs that involve heavy lifting, operating dangerous machines, continuous standing, or working with toxic substances are contraindicated during the pregnancy. Radiation should also be avoided. Tetragenic factors. Some fumes, chemical substances, and infections are known to cause fetal defects. These environmental damaging agents are called tetra- teratogens. Most teratogenic effects occur in the first trimester of the pregnancy during the the critical period of development of the embryo. The woman may not even know yet that she is pregnant. Teratogenic uh, events occur after fertilization and are not genetic, meaning they're not inherited, although they are congenital, meaning present at birth. Maternal um, dietary deficiencies and food, air, and water pollutants may play a role. Radiation is particularly dangerous. The followings are some examples of teratogens. That's diseases such as rubella, herpes, toxoplasmosis, syphilis. To avoid the infections of toxoplasmosis, the pregnant woman should not handle cat litter and should cook meat well, especially poultry. She should wash her hands carefully after handling raw meat and wash all fruits and vegetables thoroughly before eating them. She should wear gloves while gardening and cleaning. Prescribed medications like phenotone, lithium, valproic acid, isotretinoin, and warfarin have each been associated with teratogenesis. I would know that. Substance of abuse. I would definitely know the prescribed medication. Substance of abuse. The provider should, with substances of abuse, the provider should obtain a complete substance use history at the first preconceptional or antepartum visit. If the mother uses tobacco, alcohol, or recreational drugs, she is strongly advised to stop. Street or recreational drugs, such as amphetamines and stimulants, can cause fetal difficulties. The danger seems to be greatest early in pregnancy. Alcohol is the most widely used substance and also the most damaging to the fetus. Heroin can cause congenital addiction. You got cocaine, it may be associated with long-term behavior and attention problems in child born to a mother who used it during pregnancy. So that child may have long-term behavior and attention problems. Other recreational drugs are either known or suspected teratogens, and you can find that shit in those chapters and those chapters. Let me delete that. All right, ionizing radiation. This is the type of radiation exposure that is used in treating cancers or that occurs with a nuclear plant accident. Nursing alert, caution the pregnant woman to not take any herbs, drugs, or medications without asking the healthcare provider. Laxative, diuretic, stimulants, and depressants are particularly dangerous. These are extremely dangerous. and many herbs are also not proven safe for the fetus. Nursing alert. If you suspect any type of drug abuse in a pregnant woman, notify the healthcare provider. Nutrition. Let's see. I'm gonna do this one. Let's see. I'm trying to see when I'm gonna take a break. I think I'm gonna take a break. Use all this shit. One, two, three, four. Yeah, I'm gonna take a break. I'll finish the rest of this shit tomorrow. Five, six. Fuck all that. Yeah, it's break time. Or I'll doze off on y'all ass. Okay, we'll pick up tomorrow. All right, so let's talk about the nutrition during pregnancy. One of the earliest and most important purposes of prenatal care has been to counsel women and ensure that they receive adequate nutrition to support themselves and their growing fetus during pregnancy. Study shows that a newborn chances for good health are greater with a reasonably high birth weight. The nutritional requirements of a pregnant woman differs from those of a non-pregnant woman. Okay, so the woman's caloric needs increase during pregnancy because, hold on, I knew that was finna drag. Um, so I think this is what we need to know right here. The woman's caloric needs increase during pregnancy because she needs to meet energy requirements for fetal, placental, and maternal tissue development. So know that the caloric needs are going to increase. They're not going to decrease, they're going to increase. The quality of the diet, not the quantity, matters most. So it's not about what you eat, it's the quality. Well, it's not about how much you eat, it's what you are eating. That's what matters most. And the pattern of weight gain is more important than the total amount. Okay. So I think all of that is important. It's not about the quantity. It is, it's not about how many hamburgers. Well, it's not about you ate a whole lot of food. It's about what is the food that you ate. What is the quality of the food? Are you eating your fruits? Are you eating your fiber? Your vegetables and drinking plenty of fluids, water to keep you from getting constipated. And on top of that, are you eating the correct minerals and vitamins? So to obtain the necessary distribution of nutrients, foods for the pregnant woman should be selected from all food groups. Exclusion of any group may lead to a deficiency of one or more nutrients. So don't exclude anything out. You want to eat, like, eat the color of the rainbow. So the guidelines for pregnant women are basically the same as the general guidelines for healthy eating. It is suggested that the pregnant woman increase her intake of milk and milk products. So I would know that. It is suggested that the pregnant woman increase her intake of milk and milk products. The pregnant woman should make the following dietary adjustments. So, caloric intake by approximately 300 calories daily. Know all of these. Let me, yeah. The pregnant woman should make the following dietary adjustments: increase caloric intake by approximately 300 calories daily, increase calcium intake before the half of the pregnancy, increase milk intake to 3 to 4 cups daily. I will know that. Supplemental calcium is sometimes prescribed. Rationale, the reason behind that is calcium is essential for the development of the fetus bones and teeth and for blood clotting. Maintain iron intake. Most providers order an iron supplement during pregnancy because of its dietary importance. And the rationale behind it is iron is essential in production of hemoglobin. So, because breast milk contains little iron, the developing fetus stores iron for the use, stores iron, yeah, for use after birth. So, I think everything that I highlighted in this little section is very important for the nutrition. Also, it says maintain folic acid. We already know that need to be 400 grams. It's really milligrams of folic acid daily in a supplemental. Well, in a supplement is recommended for all women of childbearing age when not pregnant. In addition to food sources of folate during pregnancy, the recommendation increases to 600 micrograms from a supplement plus food sources. So during pregnancy, the recommendation increases to 600 micrograms. So it says 400 when for our women of childbearing age when not pregnant, but it's 600 when you get pregnant. I think I said 400 earlier, and I guess that's for prenatal. Well, preconception before you even become pregnant. But 600, yep, that was for preconception at 400. So once you become pregnant, 600 micrograms from a supplement plus food sources. Most prenatal vitamins contain 1 milligram of folic acid. Most prenatal vitamins contain 1 milligram of folic acid. Rationale behind that: folic acid, B vitamin. B vitamin helps to prevent congenital neural tube defects, most notable spina bifida or bifida, one of them. So increase. Also, you want to increase intake of most vitamins. Many physicians prescribe supplemental vitamins during pregnancy. So increase most vitamins, increase protein intake. The rationale behind increasing the protein intake is essential to the building and repair of all body tissues and aids in the production of milk for the nursing mother. That's why you want to increase protein because it is essential to the building and repair of all body tissues and aid in the production of milk for the nursing mother. You want to avoid empty calories. When I say avoid empty calories, that means avoid empty calories, including alcohol, sugared sodas, drinks, other sweets, and salty foods. So you definitely want to avoid alcohol. And I mean, you can have, sugars and sweets and salty foods, but you want to try to avoid them as much as possible. So that means you really need to limit. But it says avoid empty calories. So if it says avoid it, we're not going to sit here and say limit. If that test says something about avoid rather than limit, we're going to go with what the book says. Use iodized salt. Rationale is going to promote proper function of the thyroid gland. We all know that. Eat a wide variety of food. Rationale: a variety of food will encourage proper nutrition, especially during the first months of pregnancy if the woman is experiencing nausea. So eat a wide variety of food. Avoid laxative and enemas unless the physician specifically ordered them. Soft stool softeners such as dicosate sodium, which is colas, or ordered more often than laxative. Fiber is also essential to prevent and to treat constipation. So, they need to increase their fluid intake. Stool softeners such as dicosate sodium, okay, they are ordered more often than the laxative. So they're going to give you a stool softener versus a laxative. You're going to get a pregnant woman, she's mainly going to get a stool softener versus a laxative. Um, Increase fluid intake to 10 glasses daily to assist in kidney and bowel functioning. Water is is the preferred fluid. Water, I'm gonna highlight that whole thing. That rather you drink water than sitting here drinking pops and teas and shit like that while you're pregnant. When providing prenatal nursing care, keep in mind a woman's general health, age, culture, and religious background, and her likes and dislikes, food allergies or sensitizations, and socioeconomic status. These factors will affect her diet and pattern of weight gain. So when we say anything about socioeconomic status, if y'all don't know what that means, that's basically like the community she live in. Is she in the suburbs or is she homeless? Is there money? Basically, is it poverty? Even if she's not homeless, is she's living in poverty? Because that all plays a role in what you're eating. Like if for a lot of people that live in the hood, they may have a bunch of McDonald's and Burger Kings and shit like that around them, rather than having healthy foods like shit like what's the name of that, like Smoothie King and shit like that, or just fresh foods, restaurants that carry fresh foods and promote fresh food, or subways, shit like that. So they're going to be around in a low income area. That is, you know, that is why it's a lot of obesity in those areas. Or if they have a county market or a Piggly Wiggly in that area, they pretty much don't, you know, they don't sell a lot of healthy shit out of there. They sell a lot of cheap ass food. And so if she's living in poverty, if the parents are living in poverty, that's where the socioeconomic come from versus the suburb. You live in the suburb, you're probably by a Whole Food store, you're by a Target, you are by a lot of healthy places. A lot of healthy fast food restaurants. So just keep that in mind for socioeconomic. And like I said, these factors will affect her diet and pattern of weight gain. Dietary counseling should begin at the first visit and continue throughout all visits, all follow up visits. Instructing the client to make a sample diet for review is useful in determining needed dietary changes. So you'll have that client, okay, sample this diet out and let me know how this shit work. You know what I'm saying? So appetite. With the appetite changes in a woman's body during the early part of pregnancy may interfere with her appetite. So attention must be given to supplying her with proteins, vitamins, iron throughout pregnancy because the appetite is going to change. So many pregnant women find that they are extremely hungry after the first few weeks. They should monitor what they eat and be careful not to fill up on empty calories. I would know that because empty calories came up like somewhere up in there. So remember that. High rich spice and fried foods are undesirable. When it was rich, highly spiced and fried foods are undesirable. Rich, highly spiced, and fried foods are undesirable. In the late months of pregnancy, several small meals daily rather than three large ones will probably help her feel better. So, several small meals rather than with just one big ass meal will probably help the mother to be feel better. The pregnant woman will not have uh, as much space in her abdomen for a distended stomach. Beverages and foods that contain caffeine can be harmful to the pregnant woman. I will put that down. Um, Items containing caffeine include coffee, some teas, most colas, several other soft drinks, and chocolate in candy or in beverages. Caffeine may contribute to mastitis, which is an inflammation, swelling of the breast tissue in the woman that can cause irritability in the fetus, especially if the mother is breastfeeding. Caffeine also crosses the placenta. Caffeine also crosses the placenta during pregnancy. That is so doggone important to know. That's why you don't want to give caffeine because caffeine is going to cross the placenta during pregnancy. Okay. So I think that may be on the test. I will, if I was a teacher, I'll put that shit on the test. Pica. Pica is an abnormal craving. Y'all know, like when people crave dirt. Some people, yeah, here you go, dirt, clay, cornstarch. Those are abnormal cravings. It's non-food. I didn't crave no shit like this. Now I used to crave that when I was little, but that may have something to do with iron. That may have something to do with a low iron when they get the craving dirt and clay and cornstarch and shit like that. When I was younger, I used to crave powder before they started putting that damn the Johnson and Johnson powder. Before they started putting all that perfume and shit in there, I used to turn that bitch up. So if left untreated, pica can lead to serious nutritional and other physical disorders. So we don't want the woman around here digging and eating clay and dirt and cornstarch. All pregnant women should gain weight. All pregnant women should gain weight. Okay. She shouldn't just not gain weight. Now, if she's not gaining weight, it's something going the fuck on. So all pregnant women should gain weight. And we definitely need to know what pica is. And I'm gonna highlight out there. Know that that's the craving of dirt, clay, and cornstarch. All pregnant women should gain weight. And assessing maternal weight gain, other helpful guidelines include the following. By the week 20th week of gestation, by the 20th week of gestation, all women except obese women will have gained approximately 10 pounds. Any women, any woman who loses more than 8 pounds during the first trimester is at increased risk. I would know that weight loss during pregnancy is never recommended. I would definitely know that. And I would know about this too. By the 20th week of gestation, all women, except big women, obese women, they should gain at least 10 pounds. Although weight gain itself is critical, equally important is the quality of food leading to the weight gain. For example, a woman may easily gain weight on a cookie, chips, and soda diet, but may not be well nourished because we know sugar causes, regardless if you are pregnant or not, sugar is what makes you fat. It is not greasy foods that make you fat. It's not fried foods that make you fat. It's sugar. Because if you eliminate sugar for about a month, watch your ass drop about 30 pounds, if you're overweight. So sugar is what makes you fat. And if you got a pregnant woman and she's consuming a lot of sugar, it's not healthy because that's not a nourishing diet. So keep that in mind because it's all about the quality of food. It's all about the quality of food. It is not about the quantity. It's about what are you eating, during pregnancy. Common discomforts of pregnancy. Even in normal pregnancy, it is common for the woman to have some unusual, sometimes uncomfortable sensations. These are the common discomforts of pregnancy. They are considered minor, not in the sense that they do not cause true discomfort, but because they are not serious and do not threaten the life of the fetus or the mother. However, sometimes it is difficult to tell what is truly a common discomfort or when a symptom may be a warning sign or more serious problem. So we're going to go to 65-1 to tell us what that is. So this right here, this is showing us, the common discomforts of pregnancy. So I think I would definitely remember this because we want to know what are some comforts. If we've been pregnant, we should be able to try to remember some of these. Okay, so it says integument. So this is going to be the skin, inching of the skin, stretch marks, melasma, meaning increased pigmentation, sleepiness, moodiness. That's all falling under, I guess it's all falling under the integument. And then right here, we got the musculoskeletal. So there's low back pain or body aches, Braxton Hicks contractions. I never had contractions. Thank you, God. Don't know what they feel like. Round ligaments pain. And then last, you got the reproductive, which is vaginal discharge. So let's go back up and talk about the integument. So inching of skin. The probable cause or contributing factor is stretching of skin over breast and abdomen. That's why you got itchy because the skin is stretching. So relief, you can bathe with baking soda, cornstarch. Don't eat the damn cornstarch, just bathe in it, or colloidal oatmeal and bath water. Use little, if any, soap, because that soap will dry the skin out. And you remember, we don't put soap on the nipples. We do not, put any type of soap on the nipples because the nipples secrete its own oils to keep the nipples from getting chapped and dry. Watch for sensitivity to soaps and detergents. Use moisturizers. The danger signs, it ain't no damn danger signs because you itchy. Stretch marks, striae, gravidarum. The probable cause would be hormonal changes of pregnancy and hereditary. It can be a hereditary thing. Relief would be using soothing oils like coconut oil, vitamin E. This shit ain't work for me. I still got them. They're white. Some of them dark, some of them white. So these are just what you can use. You can use a half a cup of virgin olive oil, um, 1/4 cup of aloe vera gel, 6 capsules of vitamin E, 6 capsules. I wouldn't remember the number. I definitely wouldn't remember the number. Just know you can use olive oil, aloe vera, vitamin E, vitamin A. It says mix together, refrigerate, apply twice daily. I'm gonna try the shit now and see if that shit go away, but I doubt it. Danger signs, none. Melasma, y'all remember that was that increased pigmentation when you start getting bronze and skin start getting a little bit dark. So they said this really happened in dark haired women. So that'll be our black asses. Um, well, except you, Heather. It'll be us African American women or just anybody with dark hair. So relief measures, avoid sun exposures, wear hats, use sunblocks, adequate folic acid intake, advise women that it may or may not resolve after the birth, and danger signs are none. Um, so this is what you can do. Like I said, for relief measures, sleeplessness, probable cause would be overexhaustion, dreams, stress, excitement, hard to find a comfortable position. And the relief measures is use pillow to help find comfortable position. Use herbal teas, cal- chamomile, however you pronounce that. That's a tea. Lemon, um, m- measure, marjoram. Never heard of it. See, I'm gonna have to look that up, see what that is. Hot milk with honey. Oh, I guess it helps you sleep. So no heavy meals before bedtime. If cannot sleep, get out of bed and read or take a warm bath or shower. And this danger signs is depression when you can't get any sleep. You become very depressed. Moodiness, that's the superwoman syndrome, hormonal changes. This what's caused it, probable cause. Superwoman syndrome, hormonal changes, adaptation to life changes. So you get moody, right? So the relief would be emotional self-care. Spoil yourself. Go get your feet done. Go get you a massage. Take a warm bath, not a hot bath. Just rest. Sit your ass down and rest. If you can, nurturing from family and friends, so that's why it's very, very careful about who you have a child by. Make sure that you can be able to do some of this shit. And danger signs would be depression, suicidal thoughts, extremely motherfucking moody. Okay, so those are signs for that. Musculoskeletal, so that would be low back pain or backache, and the probable cause would be due to relaxation of joints and ligaments, weight of enlarging uterus, increased lordosis. And this is the relief measures. So you want to practice good posture, wear flat shoes with good support, pelvic rocking, walking, good body mechanics, apply small amounts of salve to back, such as Tiger Balm, Camphor, menthol, menthol, peppermint clove, and Kaja put, whatever the fuck that is. And then danger signs is if a woman's still having if she got a kidney infection, that means one-sided pain, fever, chills, and you know what kidney infection would be like a flank pain if she had some flank pain going on. Braxton Hicks contraction, the cause of that is uterus readying itself for labor may occur with breast stimulation or orgasms. Those Braxton Hicks contractions, they may occur with breast stimulation or orgasms. And the relief would be reassurance. Take warm baths or showers. Use herbal teas like red raspberry and sarsaparilla. Perilla. I think I had some there before. I think I still got that. That shit nasty. And then also preterm labor. Preterm labor is a danger sign. So y'all remember when it said orgasms can fuck around and stimulate um contractions, or can stimulate, fuck around and stimulate um what you call it? Labor. Labor. And then we got round ligament pain. And with round ligament pain, it says enlarging uterus stretches ligaments. Enlarging uterus, it stretches the ligaments, and it may be felt on side of abdomen and groin and outside the vagina. May be felt on side of abdomen and groin and outside the vagina. The what you call this is the relief measures. So for the relief measures, heat, massage, rest, avoid sudden movements, bend slowly toward pain to allow relaxation. And the danger signs would be preterm labor, abdominal problems, and infection. Reproductive is vaginal discharge. And the causes would be due to estrogen stimulation of glands of cervix and vagina, estrogen stimulation of glands of cervix and vagina. And the relief measures would be avoid soaps to the vulva, wash with clear water as needed. Hmm. Some people need soap. I'm sorry. Now I wouldn't recommend that you dish. Avoid anti-itch creams containing steroids. I don't know what can you must gonna use some damn spring water down there, but for some folk, they can't go without no damn soap. I know you're not supposed to put soap down there, but come on now. Danger signs, danger signs. Severe itching, odor, lesions, pain with intercourse, bleeding after intercourse, pain, partner with complaints of discharge from penis or lesion. You need to get rid of his ass. Okay. Um, and also this is continued. Damn, I thought I was damn near done with that. Ooh, it's a lot. Okay, well, we need to know all this shit. So, right here, we're talking about symptoms, breast enlargements, and tenderness. I would know every fucking last one of these. So let me go up and highlight that, highlight that. I would know every last one of these motherfuckers. Every last one of them. Okay. Especially the ones that got danger signs. So breasts, let's talk about these big titties. So breast enlargements and tenderness, the cause would be due to hormonal changes in preparation for lactation. The relief measures, wear a supportive bra, practice good posture, breast care, wash with water only. Remember, do not wash with soap. You're going to wash with, and this is what may be on the test right here. Wash with water only to keep the oily secretion um, from Montgomery follicles on the nipples and areola. Danger signs if you got some breast masses going on. The nose, nasal, stiff stuffiness or bleeding that can be caused due to allergies, common cold, increased number of capillaries. Relief measures, use normal saline nose drops, use cold compresses, use cool mist humidifiers, decrease dairy products in the diet, increase dairy products in diet if there's some of this going on because it can be due to allergies. Danger signs would be severe nosebleed may indicate high blood pressure. Severe nosebleeds may indicate high blood pressure. That's one I may know. Try to remember mouth sore of sore or bleeding gums. That the cause of that is increased blood supply, poor oral hygiene, or gingivitis. Um, Relief measures will be vigorously brush teeth and gums with soft toothbrush, floss regularly, massage gums, consume adequate vitamin C. I would know that. Overgrowth of gums onto overgrowth of gums onto teeth. This may require oral surgery when there's an overgrowth of the gums onto the teeth. Excessive saliva production. This is pop Patiolism, and I'm probably still saying it wrong. The cause is unknown. Ask about Pica. If they got that going on, you can ask about Pica. I will know this too. The the relief measures would be consume small, balanced, frequent meals, chew gum, suck on oral um lozenges, that is what you call them, damn cough drops and shit, or hard candy. Increase fluid intake to compensate, and there are no danger factors from excessive saliva. GI would be food craving. So with the food craving, it may be social custom, or it may be caused by maybe social custom, or may indicate lack of certain nutrients in diet. When you start having a craving, they may have something to do with pica too. So reinsurance, complete diet review, avoid unhealthy foods, limit consumption of non-foods. Pica, see, pica. And the danger signs is pica may replace nutritious foods. Okay, I said that. I would know this. Pica may replace nutritious foods, excessive weight gain due to consuming like junk foods, well, food or excessive sweets, heartburn. With heartburns, the causes would be slow stomach emptying, acid reflux into esophagus. And the relief measures would be consume small frequent meals. I would know that. Avoid caffeine. I would know that. Sip on water, milk, or soda. Eat a tablespoon of yogurt. If sit up if happens when lying down. I would know that. Try to avoid antacids. Try herbs. Papaya has digestive enzymes. Anise or fennel seed tea. Anise is a tea. Um, or fennel seed tea after meals and slippery elm powder. All of these things are good for heartburns. And the danger signs would be ulcer, GI bleeding, ulcers and GI bleeding. That is very dangerous. Um, constipation would be slow GI. The causes would be due to slow GI motility, pressure of the uterus on intestines, iron therapy, limited water intake. I'm doing that for iron therapy. Limited water intake. Yes, trying to um, avoid having a bowel movement when it is painful due to hemorrhoids or uh, fissures. I would definitely know that because a lot of us end up getting hormones and didn't get them until we had a baby. Now I had hemorrhoids before then. I got hemorrhoids back in high school. Okay, so the what is this called? Shit, the relief measures. Increase fluid intake, increase fiber, like bran fruits, dark breads, vegetables, prunes, raisins. If laxative needs, I think I would know this. If laxative needs, they really said we didn't give laxatives. They said we usually give stool softener, but if laxative is needed, use only bulk laxative. I would know that, such as Metamucil. Increase activity level. And this would be a danger sign would be fecal impaction. We don't want that to happen. And then nausea and vomiting of pregnancy. The cause would be due to decreased stomach motility, increased HCG levels, hereditary, uh, dietary, and socioeconomic factors. And the relief measures will be eat small frequent meals, eat snacks high in complex carbs on at onset of nausea, avoid heavy meals, excessive fats, and excessive spices. Try peppermint tea, soda water, ginger tea. Eat sour, eat sour, salty foods, potato chips, and lemonade. I would definitely put that. Um, and the danger signs would be weight loss of more than 8 pounds, starvation, loss of appetite, eating disorders, GI disease, um, such as ulcers, gallstones, liver disease. Moving on, we're talking about hemorrhoids. We're talking about hemorrhoids. Symptoms would be what are called to be varicose veins or hemorrhoidal veins, increased pressure from constipation, relief measures, avoid constipation, use cold witch hazel compresses, try topical anesthetics, take sitz baths, rest on side, rest on left side with feet slightly raised. Those are the relief measures for hemorrhoids. And then danger signs will be excessive pain, excessive bleeding. Okay, so this is what we can do for hemorrhoids. Neurologic, when there's headaches going on, the cause could we don't know. So possible causes can be a sinus infection or eye strain going on. So relief measures would be rest, darkness, take acetaminophen as needed. So you pregnant woman can take a Tylenol. She can take an acetaminophen. Danger signs would be if there's a one-sided headache, associated sudden visual change, not relieved by acetaminophen. Dizziness. I always fuck that word up. Syncope. Let me see what the fuck that word is. Let me see how to pronounce it. Hold on. 'Cause I'm gonna get this right. Syncope. Syncope. Okay, dizziness is and it says syncope. Syncope. Okay, so the causes would be due to pressure of the uterus on inferior vena cava when lying down. Remember when they said when I showed you the picture with that baby, when the mother was lying on her back and she was pressing down on the vertebra and the vena cava. So just that's what lying back in the supine position. So, that can cause it. Decreased cardiac return, decreased cardiac output, low blood pressure. That's from lying back. Or it can be due to some more shit going on. And the relief measures is you want to avoid lying on the supine. So avoid lying on back after 24 to 26 weeks because they're too much weight. The baby's too heavy. It's too much shit going on. So you got to lay on your left side. They rather you lay on your left side. I would know that. Left lateral position, lateral stand for side position, increases blood flow. Get up slowly from lying down. Don't just hop up and think you finna go wash some dishes and be have a superwoman syndrome. Slow your ass down before you hit the floor. And the danger signs is your ass to faint it because you want to be superwoman so goddamn bad. But it could be due to something else. So your ass will pass out. Urinary frequency, urgency, nocturia, that can be due to the causes will be pressure of enlarging uterus on the bladder, and the relief measures will be maintain good fluid intake, void frequently, decrease evening fluid intake. And what you can do right here is, well, what the danger signs are, you can't do shit, but these are the danger signs. Pain or burning with urination and a sweet smell to urine. If we know it's a sweet smell to urine, that means there's too much fucking ketones in the urine. There's something going on. And then right here, cardiovascular or varicose veins. And the causes of that, it can be hereditary. It can be due to weight of enlarging uterus, relaxation of smooth muscles and vein walls due to progesterone. And the relief measures will be avoid prolonged standing or sitting, rest several times daily with legs elevated, use elastic stockings if varicosities on vulva, apply pressure with a thick sanitary pad inside the underwear because they can get up to the vulva. That's the cooter cat, the lips. So if it get up to that, apply pressure with a thick sanitary pad inside underwear. And the danger signs would be signs of blood clots like heat, swelling, pain, and pain with walking. And swollen feet, increased estrogen. Well, the causes would be due to increased estrogen and progesterone and decreased venous return to the heart. Now, if any of that happened, what the relief measures would be elevate the legs when sitting, elevate legs above heart when lying down, or rest on left side. Perform leg exercise while standing and sitting. Ensure adequate calcium and potassium intake. Out of all these, I would definitely remember those two. Elevate legs above. I remember this one too. Elevate legs for sitting, elevate legs above heart. It's mainly that above heart when lying down or just lie on your left side. Perform leg exercises while standing and sitting and ensure adequate calcium and potassium intake. And the reason that this shit happens, I had this. This is what I had: preeclampsia due to high blood pressure. I had high blood pressure and I had preeclampsia. That's why my baby had to come early. Swelling, protein in the urine. Now we got through all of that. And I would recommend that you go over this about 3 times. And for some of us, maybe 5 times. I'm gonna go over that bitch a few more times. I know that for sure, for sure. Now, preparing to be a parent. When approaching parent in a holistic manner, hold on. And y'all know what holistic is. That's when you're caring for the patient, mind, body, and spirit, mind, body, and soul. So, when approaching the pregnancy in a holistic manner, there is an obligation to see the woman not just as a container for the fetus, but also as an individual in the context of her family and community. It is important to determine how we can best help her and her family members make the necessary transition. This section examines several aspects. Okay. So right here, categories of pregnancy, well, categories of drug safety and pregnancy. Hold on, let me see. I'm just trying to see if I put that before something. I think I did, but I ain't gonna trip. Okay, so the FDA has rated drug acco- have rated drugs according to their relative safety during pregnancy as the follows. So you got category A, B, C, D, and category X. So with category A, controlled studies in women do not, matter of fact, let me put that shit back up for a highlighter. Okay, so category A. I think I would know these categories. Let me see if they in our new book. Because I got this out of the old book. Let me see if I see something about categories. If I see something about categories, baby, we need to know that. Let me see what it's hidden from. We almost done. Yep, we need to know that shit. Sure in the fuck do. So let me see something. Hmm. Mm-mm-mm. I don't see medical intervention in this. Let me see. Was medical intervention in here? Oh yeah, we read about it. That's where this is coming from, I believe. 65 3. Yep. Um the shit we about to talk about right here, this came from the medical intervention, which was this right here when we was talking about this. This is where this coming from. So it should have been under that, but it's all good. I'm not gonna switch it. Okay, so with the medical intervention, just know that they were talking about this in medical intervention. So the FDA has rated drugs according to their relative safety during pregnancy as follows. So category A, controlled studies in women do not demonstrate a risk. Possibility of fetal harm appears remote. Category B, animal studies fail to demonstrate fetal risk. And there are no controlled studies in women or animal studies showing adverse effects, but the same effect was not confirmed in studies in women. Category C, animal studies have demonstrated fetal risk, but no controlled human studies are available, or studies in women and animals are not available. Drugs in this category should be given only if the potential benefit to the mother outweighs the possible risk to the fetus. Category D, human fetal risk exists, but the benefits of use in pregnant women may be acceptable despite the risk, such as when a life threatening situation exists or a serious disease for which safer drugs cannot be used or not effective. Category X, proven risk exists. Drug is contraindicated in women who are or may become pregnant. So this is all for the FDA has rated drugs according to their relative safety or relative safety during pregnancy as follows. So this is about the drugs. This is the drugs and what category they fall in, whether or not if it's safety for the mother or the fetus, during pregnancy, or these drugs safety. So they're going to put those drugs in different categories to let you know, okay, it may not be a risk for the mother, but it may be a risk for a baby. And how they know that is because they tested it in a damn animal, a rat, a monkey, or some shit, and then boom, this happened in the animal, but um, the same effect was not confirmed in studies in women. You know what I'm saying? So these are the categories. I think I would know that. I would definitely know that. Most drug handbooks identify the pregnancy risk for each drug. Note, drugs are particularly dangerous to the fetus in the first and the third trimester. This is definitely what I would know about it is. Drugs are particularly dangerous to the fetus in the first and third trimesters. In the first trimester, the fetus is being formed and is particularly sensitive to Teratogens, that is those different type of things or drugs that can cause a defect in the child. So that's what that is talking about right there. Drugs administered in the third trimester are dangerous to the fetus because when the fetus is born, the woman's circulatory system is no longer available to help metabolize or excrete, and the newborn's immature circulatory and ex- excretory systems must take over. So, drugs administered, I would know that. If we didn't got to know the damn categories, I feel like mm, this is definitely something that we will have to know. Shit, all of that. I should have used my finger for that. All of this. I would definitely know that. Okay. So let's talk about adapting to pregnancy. Now, when we talk about adapting to pregnancy, pregnancy can be seen as a developmental crisis, a time of both challenge and opportunity. In the earliest stages of pregnancy, it's very common for a woman to feel shock, disbelief, and sometimes denial to adapt to the pregnancies. There are several stages through which a woman must progress. Pregnancy validation. So, first trimester, between the 1 to 13 week, the task of this the task of this period of pregnancy is to accept the pregnancy and all that it means as a reality. Common responses include ambivalence, shock, disbelief, self focus, and fear, particularly if the woman had a prior negative pregnancy experience. So that damn ambivalence, if I'm saying that right. Hold on, let me see what that word means. Ambivalence, and that means uncertainty, uncertainty, like doubt or hesitation, hesitancy, conflict. That's what that word means. So common responses include um, ambivalence. And like I said, ambivalence may be doubt, shock, disbelief, self focus, and fear. That's in the first, like the day 1 to the 13th week. Fetal embodiment, that's going to be in the second trimester. I might know these. In the second trimester, during this phase, the task of the pregnant woman is to incorporate the fetus into her body image and to begin to see herself as a mother. Often, the woman becomes more able to identify with her own mother. She may relive and reevaluate all aspects of this relationship. Common responses during the second trimester include increased dependency, excitement when quickening, first sensation of fetal movement, and occurs calmness, increased libido, and buying maternity clothes. I ain't do none of this shit. But in women it's different. Um, I must have been a man in my past life because I ain't give a damn. It was what it was. So in the third trimester, I did not buy no goddamn maternity clothes. I just had big ass clothes. In the third trimester, with the fetal distinction. At this stage, the pregnant woman must learn to see the fetus as separate from herself in preparation for the birth. This is often called a period of watchful waiting. I will know about the period of watchful waiting. That's going to happen in the fetal distinction, which is in the third trimester. So the woman may exhibit motherly behaviors such as reading to the fetus, stroking her abdomen, preparing clothes, choosing a name, and reading books about childbirth and parenting, such also may experience fear related to the birth. Now that was me. Her survival and the survival of the infant. My baby was playing, but I was still scared in the motherfucker. So often these fears lead to dreams of danger. Many women experience a slight depression late in the third trimester. That's because I was getting big and black, like Wesley Snipes. Um, Separation from the fetus, labor and birth. It's okay to be black, but not big with it. That was my whole damn thing. Um, as a woman, now it's some big fluffy dudes out there that it look good on, but you're a woman, hell to the now. Um, but everybody different, and you know, I just don't. I don't like being the big woman. That's just me. And I know I'm up there. Now I'm a little thick, but no disrespect. So with the onset of labor, then the inevitability of separation becomes clear. Although in many ways this separation is desired, there is usually some, oh shit, this word keep coming the fuck up. Doubt. We know this doubt about the losses being the center of attention. That's what the fuck was going on with me. The physical separation from the baby and the fear about the process of labor and birth. Common manifestations of the fear include frequent visits to the hospitals or birth centers to assess the onset of labor and needing constant reassurance that she and the baby are doing well and can um, complete this step. Transition to motherhood. Transition to motherhood. Maternal infant bonding is a process that begins during the pregnancy and accelerates immediately after the birth. Strong bonding increases the mother commitment to the infant and also her ability to be an effective parent. Bonding of the mother and child is helped by immediate maternal infant touch, visual contact, suckling, and vocalization by the mother and the infant. I didn't get cool with my baby until he was up in months because I didn't have him for the first few months because his grandmother took over. Behavior that indicate positive attachment includes fondling, kissing, cuddling, and gazing. That's so sweet. I guess that's what he was doing with his grandma because we didn't do that shit. She took his ass as soon as his ass was born. Came home from the goddamn NICU. She took my baby. Okay, so preparing the labor and birth. As the woman enters the final phase of pregnancy, she becomes more focused on labor and birth and typically is eager to plan for these events. Planning may include choosing a site for the birth and a birth attendant. Um, that's if this has not already, you know, done, has not already done. And developing a plan that reflects her desires regarding the conduct of labor and birth, including analgesias and anesthesia um, alternatives. So this is preparing for the birth. So some women want to get an epidural, some women don't. Some women just want to go straight through the pain. Some women can't stand the pain. I ain't need none. Well, I needed that to get a. Well, hell, I got an epidural. So, but I didn't have no labor pains, no cramps, no nothing, no contractions, no nothing. Thank you, Lord. So this is preparing labor and birth. Safety for herself and fetus is the overriding concern in planning for labor. Safety, however, means different things to different people. For some women, safety means immediate access and probably use of the highest level of technology available. For others, the hospital environment may seem inherently unsafe. For these women, safety may lie in attendance by a trusted midwife or physician, maintaining control over any interventions considered, and having family and friends with whom she chooses to have stay with her during the labor and pregnancy, well, labor and birth. For most women, safety lies somewhere in between these two choices. Only the pregnant woman herself can decide what safety means to her and how to have the need for safety met during labor and birth. During the prenatal period, she may wish to explore the alternatives open to her and evaluate them in light of her own values, beliefs, and goals. As a nurse, your task is to support her in the choices she makes. That's what we do as nurses because it's pretty much the woman, what she feels is safety. There are many excellent methods of educating women and their partners or support person about birth, well, about childbirth. Childbirth education should include Childbirth education should include information about the process of birth, exploration of individual fears about birth, mechanisms for alleviating the pain and working through the fears of childbirth, discussion of options in labor and birth and how to promote having a normal labor. This may include choosing the site and attendant, discussing positions for labor and activity, hydration during labor, nutrition during labor, analgesias, anesthesia, optioning surrounding the birth itself, like the presence of family, friends, and siblings, positioning positions for birth, use of labors, delivery, recovery rooms, episiotomy. I guess that's supposed to be the that may be the epidural. I think I'm gonna look it up. Immediate contact with the neonate. That's immediate contact with the new baby and immediate breastfeeding. So as soon as that baby come out, some women believe that you should immediately breastfeed and have immediate contact with the baby. Now, let me see what the episiotomy word means. That means episiotomy. Episiotomy. That means a surgical cut made at the opening of the vagina. Oh, okay, okay. So that is a surgical cut. It ain't got nothing to do with no damn epidural. But that is a surgical cut made at the opening of the vagina during childbirth to aid a difficult delivery and prevent rupture of tissues. That's what that is. And discussion of possible complication and potential interventions. This should not be the primary focus of the course, though. And postpartum options, such as the amount of contact with and care of her baby, establishing breastfeeding or breast care if bottle feeding, time of discharge, danger signs, basic of infant care, and postpartum contraception. Approaches to childbirth preparation, common methods of childbirth preparation. So we got nature childbirth consists of progressive relaxation and abdominal breathing techniques that are taught to the expectant mother and her partner. Hypnosis, when used in childbirth, is a combination of relaxation and conditioned reflexes. It uses a normal breathing pattern. A healthcare provider trained in hypnosis and childbirth works with a mother and her significant other. Right here, we got right here it talk about the LeMay's method of childbirth. And basically, this is the most well-known model for childbirth preparation. It's the LeMay's method. I think I would definitely become familiar with this. The two components of this method are education and training. Using the theory of conditioned reflex, expected women are trained in toning and relaxation exercises and breathing techniques, which use three levels of chest breathing for different stages of labor. Current childbirth preparation trends. This is currently the childbirth preparation movement is steering away from specific breathing techniques and toward assisting a woman to find her natural ways of coping with stress and pain. Many women find the following methods helpful: vocalization, massage, water therapy, visualization, relaxing music, and subdued lighting. That's for the current childbirth preparation trends. Regardless of the approach to childbirth preparation, it is essential to communicate to the family that the goal of childbirth is to have a healthy mother and baby. Health is more than the physical event of labor and birth. It includes family interaction, bonding with the infant, and the successful transition to a new phase of life. Right here, we're talking about childbirth education some more. So just know there are many excellent topics about childbirth that will help women, that will help women and their partners or support person develop understanding of the processes. Childbirth education topics should include information about the process of birth, exploration of individuals' fears about birth, mechanisms for alleviating the pain and working through the fears of childbirth, discussion of options in labor and births, and how to promote having a normal labor. This may include choosing the site and attendant, discussing positions for labor and activity, hydration during labor, nutrition during labor, analgesias, anesthesia, options surrounding the birth itself, presence of family, friends, siblings, physicians for birth, use of labor, delivery recovery rooms, epistomy, epis, episio- episiotomy. Um, remember that was the cutting. That was that cutting, so the baby can come out. immediate contact with the neonate, which is the baby, and immediate breastfeeding. Discussion of possible complications and potential intervention. This should not be the primary focus of the course, like I said already. So postpartum, okay, so I didn't read this shit before, but it was in the old book up in here. It was up in here somewhere, but okay, I will. And postpartum options such as the amount of contact with and care of her baby, establishing breastfeeding or breast care if bottle feeding, time of discharge, danger signs, basic of infants care and postpartum contraception. So I would know that. I just repeated all this shit again. That's all I did. Okay, so let's talk about them daddies. Let's talk about the daddies now. Responses to fatherhood. In many pregnancy, the father is the one person whose changing roles and developmental tasks do not receive serious consideration. The pregnant woman receives attention. The children in the home receives attention, but the new father needs are often unrecognized and unmet. Man, fuck they ass. So anyway, paternal responses to pregnancy include first trimester, fear losing his wife and the child, and has self doubt as to his compatibility as a future father. Oh, it's so sweet and sad. How you have to go through that? Well, some of them do, some of them don't give a fuck. Second trimester has increased respect and awe as quickening occurs. Oh, sees the fetus as a new person, begins to consider names for the fetus. Like we talk about the baby daddies here, y'all. In the third trimester, fears harming the fetus during sexual intercourse. Some of them do, some of them don't give a damn. They be trying to get off, um, or get in, shit, and get off. Yet finds sexual abstinence, what however you pronounce that, when you're not fucking, is difficult. Has envy or pride at his wife, creativity, worries over the birth, and is keenly aware of male and female differences. And then throughout the pregnancy, um, your baby daddy may feel like he has increased romanticism, increased nurturing, increased participation in family life, anxiety about costs, and concerns about his lack of skills in infant care. Anyway, so moving on, we're talking about the preparing for the expanded family dynamics. Now, the family unit will evolve with the new changes. Major changes in the family occurs because of the economic costs of pregnancy and a new family member. Healthcare costs escalates during the pregnancy. The pregnant woman may need additional emotional support as well as additional physical care if complication develops during the pregnancy. The woman who is at risk of preterm labor or who is simply 39 weeks pregnant and ungainly may not be able to perform her usual household and familiar chores. Siblings often react to a pregnancy by regression in behavior and attitude because they fear that they will be replaced or unloved. If older children originate in another biologic family, if they are stepchildren, adopted, or living in a blended family, such fears and behaviors may be magnified. It is common for a child to regress in developmental stage, but it is often difficult for the parents to cope with this occurrence. I'll give it down. Um, Maybe the raging hormones of pregnancy can keep the woman slightly out of touch with her usual methods of coping. Because you around this bitch like King Kong and goddamn whoever else, Mike Tyson around this house, you just mad, ready to bite somebody damn ear off, with the raging hormones. So although she may normally interact and communicate in quite mature ways during the pregnancy, she may become depressed, anxious, withdrawn, or angry as she accomplishes her own developmental tasks. Such behavior changes can be hard for a child or spouse to tolerate, just as the behavior changes of children are hard for parents to accept. So this is where some counseling may come into place. Preparing for the newborn. I'm talking about newborn. In addition to anticipatory guidance, that means things that you are anticipating, you waiting to happen concerning the alteration of family structures and functioning. Prenatal preparation for first time parents involve learning the basics of infant care and preparing for infant feedings, particularly for women who plan to breastfeed. This is a need not only for the woman who will be breastfed, well, when a woman ain't being breastfed, she breastfeeding for the first time, but maybe even more important for that woman who had a previous unsuccessful attempt at nursing an infant. So the client education, so right up in here. So client education regarding general infant care should include, I will highlight all of that because I think this is important to know. I wonder if that was okay. The range of normal physical characteristics of newborns, neonatal and infant response, adjusting to the needs expressed by the infant, like attunement, sleep, wake patterns, visions, hearing, startle, reflex, and so forth. Holding the infant, skin care and bathing, care of the umbilicus, diapering options, infant stool patterns, newborns and infant safety, including the importance of using a car seat. And right here is talking about the client education for infant feeding. So that would be widespread agreement is that breast milk is the best milk for a baby. Anybody that had a baby, and even if you didn't have a baby, we know that breast milk is the best milk. The only exceptions are women who might transmit a disease, like if you got HIV, now you don't want to breastfeed, or a medication, you taking some lithium after the baby, now you drinking them bulls again and them 211s, hell no, you're not going to breastfeed. You're not going to breastfeed. Back to smoking crack as soon as you had the baby. What the fuck you look like breastfeeding? You're not going to breastfeed. But if you are a healthy mother doing the right shit, putting the right things into your body, yes, of course, we agree that your milk is the best milk. Overall, breast milk is the best milk. But if you got HIV and lithium and all that shit in your system, now unfortunately you cannot, you know, breastfeed your baby. Little preparation is involved in breastfeeding, and the past source recommended a variety of activities to be performed, including nipple toughening, nipple rolling, and nipple pulling. None of these methods has been proven to be any of benefit to lactation, entering well either in establishing suckling or any well or in preventing nipple soreness and cracking, and they are no longer recommended. I just put when they said the best milk for your baby would be breast milk. I just my mother, well, my boyfriend mother, she ended up getting um put in. She bought me a breast pump. She bought me a breast pump, and I was milking the hell out of what I can milk. I didn't have a lot, but I had enough to feed him. But he was eating through a syringe any damn way. That's how little he was. He had to eat through a syringe. However, deciding between breastfeeding and formula feeding a baby is complicated decisions for many women. They may be shy, modest, or have concerns about the reaction of other people if they breastfeed. Baby, I took these titties out and breastfed. Well, pumped so I could breastfeed because he couldn't suck. So I breastfed as long as I could, and these titties stayed big. And I wouldn't take it back, but damn. Throughout the pregnancy, healthcare staff should make the information known that breast is best. Okay. Throughout the pregnancy, the health staff know, mama, that titty milk. Get that baby some of that titty milk, mama. That's the best milk that baby can have. You know, you probably wouldn't say titty milk, but say breast. Breast is best. Hell, but I might say titty milk to my patient. I don't give a damn. But respect each woman's. That's I'm not gonna do it in nursing school. But when I graduate, if I had to work with a mama, yeah, mama, come up off some of that titty milk for that baby, please. But respect each woman's decision at the best for her. And if she don't want to get no titty, she ain't got to get no titty. Mama, that's the damn best milk for your baby. You can say it like that. Lactation. Generally, new mothers need information regarding the following topics. nutrition and hydration during lactation, supply and demand concepts, nipple care, let down reflex, appearance of breast milk, positions for breastfeeding, experiencing pump and storing milk. So these are generally new mothers need information regarding the following topics. Like I said, nutrition and hydration during lactation. So you have to, in order for you to be able to produce a lot of milk, you have to educate, well, for that mother to produce a lot of milk, she has to understand, and we have to educate her, you need to stay hydrated for that milk to, form. Um, so for it to form and for it, a lot to come out, a good size amount to come out, she got to be hydrated. Supply and demand concept, your baby is eating a lot at that age. So, you know, to me, it's best to get a pump rather than just putting the baby on the titty so you can see if your baby is getting enough milk. Nipple care, we already said we're not gonna put no soap and shit on them, but we're gonna keep them clean and keep them from, you know, and we're gonna check on them, make sure they're not infected looking or nothing like that. Let down reflex, appearance of breast milk, what the fuck does it look like? Does it got blood in it? What color is it? We need to know what is the normal color for it. Position for breastfeeding. How should you be lying down? Should how what position should you be standing up? Expressing, pumping, and storing milk. After you're pumping. If the baby isn't directly on an nipple, you need to know where you're going to store the excess milk. After a woman has decided which method she will use to feed her infant, the preparation for that method should be focused on her specific learning needs. The woman who opts to formula feeds the infant may have educational needs about formula preparation and storage, the frequency and amount of feedings. Each woman should be treated individually so that education can focus on her particular needs. For the woman and her family, pregnancy is a type of hope, dreams, anxiety, and fears. Often it is a nurse who makes the difference for a pregnant woman in adjusting to her pregnancy, preparing for her baby, and maintaining a healthy state for herself and her child. By listening, teaching, and caring, you can be one to make the difference. You can be the one to make a difference. Many resources are available for the mother who chooses to breastfeed. That's the Leash League Guide to Breastfeeding is located on the internet. All right. So, after a woman has decided which method she will use to feed her baby, the preparation for that method should be focused on her specific learning needs. The woman who opts to formula feed the infant may have educational, I mean, who opts to formula feed the infant may have educational needs about formula preparation and storage, the frequency and amount of feeding. Each woman should be treated individually so that education can focus on particular needs for the woman and her family pregnancy. I think I just read that. Yep, that's what that is. I'm gonna erase that. I'm gonna erase all that. That's how it is in the book. Okay. All right. So nursing process. These are the nursing process overview of the. We're almost done. Thank you, Lord. So this is about the data collection and all the way to the evaluation. So this is the nursing process. We know about the nursing process. Overview of the nursing process during a normal pregnancy. So data collection, assessment priorities. You got to get the health history of both parents and their family, genetic history of both parents, ethnic background of both parents, feelings about the pregnancy, reproductive choice, OB history, last menstrual period. What was the first day of period and what was it normal? Pertinent lifestyle factors, nutrition, balance between activity and rest, sexual activity, any teratogenic factors like exposure to diseases, use of prescriptions and over the counter drugs and drug abuse, or alcohol and nicotine and caffeine. We need to know about um, pre-pregnant weight, presence of common discomfort of pregnancy, morning sickness, shortness of breath, leg cramps, constipation, hemorrhoids, vaginal discharge, gingivitis, edema, varicose veins, stretch marks, recognition of danger signs in pregnancy, and ability to state appropriate action, preparedness for labor and delivery experiences, preparedness for parenting, mother and father, effect of pregnancy on self concept, adequacy of coping skills and resources, culture influences, concern, uh, superstitions and fears, physical examination, initial visit, height, weight, blood pressure, assist the healthcare provider with the assessment and documentation of a complete physical exam that includes a pelvic examination, physical examination like return visits, weight, blood pressure, urine dipstick test for sugar, protein, nitrates, and leukocytes, abdominal examination like fundal heights and fetal heart tones, presence of edema, lab and a diagnostic test, blood tests as requested, urine tests if requested, ultrasounds. Nursing diagnosis will be activity intolerance, anxiety, body image disturbances, ineffective breathing pattern. I would know these because that's something when we are doing a care plan, we know that this client is at risk for these things. So let me go activity intolerance, anxiety, blood image disturbances, ineffective breathing pattern, decisional conflict, constipation, ineffective disabling coping, or disabling family coping, diversional activity deficit, out, altered family processes, fatigue, fear, fluid volume excess, knowledge deficit, um, and you got to be specific why about knowledge is whether slow or some shit, you need to know. Altered nutrition, high risk for altered parenting. Now, when I say altered nutrition, it's less or more than body requirement. High risk for altered parenting, altered role performance, self-care deficit, self-esteem disturbances, altered sexuality patterns, sleep pattern disturbances, urinary incontinence and stress. So these are all nursing diagnoses for that you can use to create a care plan. Now, planning for short-term goals throughout the pregnancy, the woman weight gains, overall nutritional status, and general lifestyle patterns support fetal growth and development. The woman reports she feels able to cope with the physical and emotional changes accompanying pregnancy. The woman and her significant other correctly demonstrate relaxation techniques for labor, and the woman describes uses appropriate strategies for dealing with any of the discomfort of pregnancy. And long term goals, the mother demonstrates the ability to, and that was for long term. I mean, that was for short term. And for long term goals, you want the mother demonstrates the ability to adapt to changes and to develop the psychological aspects of being a parent. The mother significant others and or caregivers demonstrate the physical and emotional capability of caring for a newborn. And then for implementation. This is the doing. This is the doing. Hold on. Let me make sure. I know implementation is doing, but I'm trying to see. Okay, yeah. I need to bring all this shit over. If they request advice in circumstances or appropriate counsel the woman or um this need to be over. Hold on. I probably ain't gotta do none of that. This is what needs to be over. I'm gonna leave it like that. If they request, this is the doing. So what are we going to do? If they request advice in circumstances or appropriate counsel the woman or couple about reproductive choices, develop and implement a teaching plan that corrects any knowledge deficits about conception, fetal growth, and development, general health practices for the women, and the labor and delivery experience. Teach the woman strategies for dealing with any of the discomforts of pregnancy that present, such as morning sickness or leg cramps. Refer the woman and her significant others to the prenatal classes. And this is evaluation. And this is the last thing we're going to do. We're going to evaluate, right, to see if any of this shit works. So we're going to evaluate the adequacy of the plan of care by assessing the woman's and her family's achievement of the above goals. If they are unable to meet key goals, the plan must be modified. The basic evaluative criteria includes maximum physical and mental health of the woman throughout pregnancy and uncomplicated delivery, a healthy mother and newborn after delivery. That's what we're evaluating for. Now, for Table 65-3, overview of the data collection and initial visit, return visits, and all visits. Physical examination, initial visit, general info, height, pre-pregnant woman, blood pressure. This is what you're going to do when she comes in. Physical examination. But let's read this first, and then we'll read that. So for physical exam, this is for the initial visit when she first come in, right? General info. You need to get the height, pre-pregnant woman weight, and the blood pressure. Physical examination, including a pelvic exam. Please get that done. So there be OB history, such as last menstrual period, first day of period, what is normal to you? Like, what does your period look like? When does it come? Is it normally, is it normal for you to have a period every month, or do you skip months? You need to know. Pertinent, pertinent lifestyle factors, risk factors, medical, surgical, or lifestyle, nutrition, balance between activity and rest, sexual activity, exposure to teratogenic factors, including secondhand smoke, culture, or ethnic consideration, use of prescription or over the counter medication, use of drugs of abuse, alcohol, nicotine, caffeine, cocaine, heroin. Also, presence of common discomfort of pregnancy. There will be morning sickness, shortness of breath, leg cramps, constipation, hemorrhoids, vaginal discharge, gingivitis, edema, varicose veins, and stretch marks. That was for the presence of common discomforts of pregnancy. Also, for psychosocial concerns, recognition of danger signs in pregnancy and ability to state appropriate action, preparedness for labor and delivery experiences, preparedness for parenting, mother and father, effect of pregnancy on self concept, adequacy of coping skills and resources concerning superstitions and fears. And up here it says with physical examination return visits will be general info will be like this is for the return visit. So weight comparison, blood pressure, urine dipstick test for sugars, proteins, nitrates, and leukocytes. I think this is at the top somewhere. This is at the top somewhere. I'm just reading it again because these two books are different. So this is from the new book, and what in the old book, it didn't put it in the chart like this. So if it's in the chart, read it. Abdominal examination, fundal height, fetal heart tones, lab and diagnostic tests would be like blood tests as requested, urine cultures if requested, ultrasound if indicated. So that was somewhere up here. I don't know where the fuck it was, but it's up here somewhere. But that is all. Please, if you look at the video and if it's something that's important, type it in the comments so I could write it in my notes, So, if it's anything that I didn't cover, make a comment so I could say, okay, well, yeah, don't send it to my don't send it to my Facebook inbox. Put it in the comments so I could come back and look at it and just make notate some notes on about what you guys think or how to remember things. Okay. All right. That's it for chapter 65, normal pregnancy.